Hello, my name is Fay Lang. I'm a radiologist who has practiced for many, many years, and for the past 3 years I've been enjoying my life in Washington, D.C., where I work at the Georgetown University Hospital. Today I'm going to be discussing the use of ultrasound in the diagnosis of ectopic pregnancy. I don't know how many of you have ever had the opportunity to visit the United States, and in particular our capital, Washington, D.C. But if you do plan a trip, I would suggest you try to come in the spring when we have our very famous cherry blossoms in bloom, and just showing you some of our highlights to visit. Our memorials: this is the Jefferson Memorial, this is the Lincoln Memorial, this is the Washington Monument, and this is our capital. So I hope you'll someday be able to see these as I do. It's a lovely city, and I extend an invitation to visit it. Today we're going to talk about the use of ultrasound in the evaluation of patients suspected of having ectopic pregnancy. The primary role remains to make the diagnosis, but other roles are expanding, and these include to screen women who are at risk, to be involved with therapies, to determine appropriate therapy, to guide therapy, whether it is with methotrexate or potassium chloride, to monitor women who have received therapy, and then to evaluate a group of women who are clinically stable and who perhaps will handle their ectopic on their own. If it no longer is alive, it may be resorbed, and we can monitor those women as well. So there are many things to consider. So when we think about the possibility of an ectopic pregnancy, I think there is sort of a three-pronged approach. One, it would be nice to know what is the pregnancy test level, the HCG level, and then how to look, where to look, and how to look for an ectopic pregnancy. So beginning with the idea of knowing a pregnancy test, what is its level, the reason we do that is if the test is negative, for the purposes of our discussion here, the patient is not pregnant. If the test is positive, then we have to consider three possibilities. She could have an early intrauterine pregnancy, normal or abnormal, and the other possibility is an ectopic pregnancy. So when we look at what is the pregnancy test level, we might think of it in terms of a discriminatory number. Some people think of it in terms of a threshold number. Now, until recently, the discriminatory number that was touted as important is 2,000 milli-international units per ml. As I'll discuss in a minute, we don't believe that this number is an effective one to use anymore. But just to mention what the difference is between discriminatory versus threshold, threshold number is the lowest number at which a certain finding may be present, in this case, a gestational sac. A discriminatory number, as the word suggests, discriminates. In other words, until recently we would say that if your HCG was 2,000 or above, you would expect to see a sac in the uterus if you were pregnant, and failing to see that would put you at risk for an ectopic pregnancy. Saying that a different way, if the pregnancy test is above a certain number, and there I was showing you 2,000, you lack an intrauterine sac, you would have to think very strongly of it for an ectopic pregnancy. We can see big, bold, capital letters in yellow, but there is that little asterisk there. And that asterisk reminds me to have you think about, is the patient bleeding? Many of these women who come in at risk for an ectopic pregnancy present with a clinical constellation of threatened abortion. That's pain and typically some bleeding and often a closed cervix. That's part of the constellation of a threatened abortion. So if they are bleeding, the patient may have miscarried. And so when you talk about bleeding, you want to know, did she pass a large amount of clot? And if she did, you might think that the HCG is positive above a certain number, and she's miscarried, but the HCG is still relatively high. Another thing to consider is to know that it was technically a good exam. If the uterus is retroverted, if she's got fibroids, if she's a heavy woman, all of these things limit the ability to have a perfectly ideal exam. And so you might have a relatively high HCG and still not see a sac. So what I'm trying to say is we have to be wary. And from the Brigham and Women's Hospital, where I used to work until just a few years ago, Peter Tubal put together and reported a retrospective study over an 11-year period where 4.5% of women had their pregnancy test level above that supposed magic number of 2,000, no intrauterine fluid, and yet 6 of 9 of those women, 9 of 202 or 4.5%, delivered a term baby. Well, that's pretty scary. So the take-home message there was not to act in haste and get a follow-up ultrasound or serial HCG levels unless clinically contraindicated. So that number of 2,000 is going by the wayside. As a matter of fact, just about a year ago, the Society of Radiologists in Ultrasound had a consensus meeting to look at this, amongst other things, when we were looking at first trimester issues. And the conclusion based on that consensus discussion, which was, by the way, just published in the New England Journal of Medicine. This is actually in October 2013, stating that a single HCG determination should not be used as a criteria if the location of the pregnancy is unknown. So a PUL is a pregnancy of unknown location. And that if you have an HCG above that 2,000 level, let's say between 2 and 3,000, although a normal intrauterine pregnancy is unlikely, perhaps 2%, most likely those people will have an ectopic versus an abnormal IUP, but we have not completely excluded an intrauterine pregnancy. If the HCG is greater than 3,000, it's even less likely to have a normal intrauterine pregnancy. Perhaps it approaches about 0.5%, but that's still not zero. So a single HCG is not effective any longer to use to determine could a patient have an ectopic pregnancy. In other words, if you're above that level, you should not conclude definitively that it cannot be a normal early IUP. So we would recommend you follow the HCG, providing the woman is clinically stable, and of course you've looked in the adnexy and you do not see an ectopic pregnancy. If the HCG is followed, you should do it every 2 days and to see if it doubles. Let's say if it was fairly low, you might wait until it gets to be about 2 to 3,000 to see if you could determine there was an intrauterine pregnancy. If it is rising, plateauing, or decreasing, that is not consistent with the normal HCG increase. Again, that should be every 2 days, it should double. And you would have to think of the possibility of an abnormal intrauterine pregnancy or an ectopic pregnancy in any of these 3 situations. So now, if you have looked at the HCG and let's say it's really high and there's no intrauterine pregnancy, we want to use ultrasound. And the place to start looking is by looking in the uterus, not looking for the ectopic, but look in the uterus first to see, is there an intrauterine sac, yes or no? Why do we start by looking for an intrauterine sac? Well, because the incidence of, if you see an intrauterine sac, the likelihood of having an ectopic pregnancy is perhaps 1 in 7,000. So statistically, if you're confident there is an intrauterine sac, it's going to be very unlikely to have an ectopic pregnancy as well. And 90% of patients who come in with a slip of paper that says roulette ectopic are going to be shown to have an intrauterine pregnancy. So how do we look at the uterus? We're going to ideally use a vaginal probe, much more sensitive to pick up early pregnancies. What do we look for when we want to determine if an intrauterine pregnancy is present? What you want to look for is the so-called intradecidual sac sign. What do we mean by that? Well, when you get pregnant, you have thickening of your endometrium. And the endometrium at that point is no longer called an endometrium when you're pregnant. It's called decidua. So you're going to thicken the decidua, and what you want to look for is, if you can find it, a line running down the thickened endometrium or decidua, which is the central cavity echo where the two walls of endometrium come together. We can see that on a scan here as a white line, and just immediately next to it you want to look to see if you can see a small sac-like structure which is rounded and surrounded by bright echoes. That would be the product of conception or an early sac. So if you can see that, you can conclude this is a positive intradecidual sac sign, and you should think of an intrauterine pregnancy. Now, I didn't say normal. It could be normal or abnormal, but you'd think of an intrauterine pregnancy. What happens if you have a different appearance? What does it mean? Well, here, I think if you look at the schematic, you can see there's fluid, but that is in line or continuous with the opposing walls of the central cavity echo. That places this fluid not in the thickened decidua, but in the uterine cavity itself. So that's fluid in the cavity, and you can see it here on this image, this ultrasound image. That is a negative intradecidual sac sign, and at that point you should not be thinking about a normal early IUP, but it could be an abnormal IUP or an ectopic pregnancy. And we have a clip here that I think will hopefully convince you that that fluid is in line with the opposing walls of the thickened endometrium or decidua, and therefore that fluid is in the uterine cavity. Notice that the fluid is not rounded, it has a pointed edge, it is not surrounded by bright echoes, and most important, it is, again, within the cavity in line with the opposing walls of the thickened endometrium. A negative intradecidual sac sign. The problem that I often will face is I see a fluid collection and I cannot see the lines where the thickened endometrial walls or decidua come together. And when I see that, it's difficult, and I would call that an indeterminate intradecidual sac sign. Now, most of those, especially when they're rounded like this and are surrounded by bright echoes of the choriodecidual reaction, will turn out to be an intrauterine pregnancy, but it could be a little more tricky in this situation. And at that point, when I call it indeterminate, although I realize most of these will be an intrauterine pregnancy, there will be a few that can mimic this finding with an ectopic. And here's a larger collection, again, where I cannot see the opposing lines of the central cavity echo, and I will conclude that's indeterminate. Here's an example of how difficult this really can be. This woman had an ectopic a year earlier. She was now pregnant. She underwent in vitro fertilization. She's 5.5 weeks pregnant. With a normal intrauterine pregnancy at 5.5 weeks, we typically expect to see a yolk sac. We didn't see a yolk sac here. And in this woman, looking at the clip, I think you can agree, there's no visible yolk sac. I went and looked at her adnexa to see if I could see any evidence for an ectopic. I did not see that. But then I came back to her uterus again, 11 minutes later, and this clearly has become flattened. This doesn't look like a normal early IUP. So what am I supposed to conclude here? This is really a pregnancy of unknown location because I do not definitely see that yolk sac. The shape of the sac is very suspicious for being abnormal. What do you do in a situation like this? I did not see an ectopic, but this lady is clinically stable. She desperately wants to be pregnant. She underwent IVF, and she's 5.5 weeks, which is sort of a cutoff for seeing the yolk sac. So what did I do? I actually brought this lady back. I wasn't willing to call this a definitively abnormal situation. and I brought her back. Since I was on call, this is a Friday afternoon, I brought her back on Saturday because I knew I'd be in the hospital. Normally I would wait a couple of days, but under these circumstances, knowing I would be in the hospital anyway, I brought her back 24 hours later, and sure enough, now there is a yolk sac seen, clearly an intrauterine pregnancy. So I'm showing you this case to stress this can be a very difficult situation. Here's another example where you might fall into a trap. Just looking at this, a rounded structure, clearly this is in the thickened endometrium in this case. We can see the central stripe. You might conclude that this is an early IUP. You might even look at this and say, well, that looks like it could be an early yolk sac. Okay, so I think there are a lot of features here that would be very suspicious for an early intrauterine pregnancy with a positive intradecidual sac sign. The situation here that's a problem, however, is this lady's not even pregnant. This lady has a negative pregnancy test and just has this little fluid collection in the thickened endometrium. I do not know why she has this, but it is not a pregnancy when the pregnancy test is negative. So we have some problems with these intradecidual sac signs, and I actually wrote about it quite a while ago now, and I had people look for the intradecidual sac sign for different people, and our statistics, as you can see, the sensitivity, specificity, accuracy varied amongst the individuals who looked, but they're not terribly good. And this led me to conclude that this finding is not particularly sensitive or specific to diagnose an early intrauterine pregnancy. And when you see a small fluid collection without an embryo or yolk sac within the uterus, ideally you want to get a follow-up ultrasound unless clinically contraindicated. I mean, if there's a large hemoperitoneum or you see an ectopic, that will change what you do here. But it is very similar to what we just discussed with the HCG level, about how an HCG level, single one, especially if it's in the range of 2,000 to 3,000, can be very problematic. And ideally, you do not want to depend upon either a single HCG determination or a single ultrasound examination unless you see that yolk sac, because you can get faked out and it can be very problematic. So follow-up scans are very, very good things to do, or follow-up HCGs. And a 2-day interval, I think, is a good way to look at these people again. Now, let's say you have a really high HCG. The woman has not been bleeding. She does not have anything in the uterus. You did a follow-up HCG and it has not doubled. We are getting very suspicious here that she could have an ectopic pregnancy. Well, how do you go about finding it? Where do you look? Well, we can see that well over 95% of ectopics live in the fallopian tube. And I'm not talking about women here who have undergone in vitro fertilization or assisted reproduction therapies, because those women have a greater variety as to where the ectopic can implant. We'll talk about that more in a little bit. But I'm talking about the average woman who comes in and we want to look for an ectopic. The tube is the place to go, and actually the ampullary portion of the tube right here toward the end of the tube by the fimbriated end is the place to look. So as we are looking in the tube, I will stress that the tube bears a fixed anatomic relationship to the ovary. So even though it may be hard to find the tube, it's much simpler to find the ovary. So what I do when I want to look for an ectopic is I seek out the ovary. And once I find that ovary, I look carefully in the vicinity of the ovary to see if I can find an ectopic pregnancy. Well, what am I going to look for? I have a variety of things I can look for. I can look for a living embryo. If I see that, I would call that my strictest criteria. And I can go all the way down to look for free fluid, my most liberal criteria, with a variety of criteria seen between the strictest to the most liberal, including looking for an ectopic gestational sac with a fetal pole and yolk sac, but perhaps no heartbeat, something called a tubal ring in the adnexa, a complex adnexal mass. I might look at Doppler. What am I looking at for flow? Developing placental or trophoblastic tissue in an ectopic location. So let's look at these different criteria. Well, this is ideal if we could see it all the time. I think this lecture would be a lot simpler, but life isn't always so simple. Here's the ovary, and then we see an ectopic with a yolk sac and a little embryonic disc. Perhaps there was no heartbeat, but I'll concentrate very carefully here to see if I can find a heartbeat. And sure enough, here we can see an embryo with a heartbeat. Very important to make sure you label your scans correctly. Failure to label, when you do a scan like this, it's very blown up. I'm very concentrated on a large image. Hard to see the relationship of exactly where I am. I mean, this could even be in the uterus. So I urge you to make sure you label your scans appropriately. This is in the right adnexa, a living ectopic pregnancy. Now, in a scan like this, I see the ovary, I see something right at the edge of the ovary. Is that an ectopic? Well, it could be, but could it be a corpus luteal cyst or corpus luteum that every ectopic pregnancy has? Well, work hard when you see something like this. What do I mean by work hard? Well, if you can, increase your megahertz, go to a higher frequency, better resolution, make your image larger, make sure you focus at the appropriate level with your focal zone. And in this case, doing this, I can now see a yolk sac. Once I see a yolk sac, I am definite that this is an ectopic. And as I said, most ectopics live in the tube, so in all likelihood, this will be in the tube. But I will show you in just a minute how I can confirm when I see something like this that it's in the tube, as opposed to, let's say, the rare case of an ovarian ectopic. We will get back to that. Here again, I'm looking and I see a round structure, and if I looked at it in all from different planes and different obliquities, I would confirm that this is round, spherical, surrounded by bright echoes. And I don't really see the ovary here, but what I see is this structure which would be consistent with a tubal ring. What we mean here is it's an early sac surrounded by developing trophoblastic or placental tissue, which is echogenic, and that's called the tubal ring. But in this case, I don't see a tube per se. I don't even see the ovary, but look very carefully for this white echogenic material, which is consistent with blood clot. And very often when you have an ectopic, especially if there's leaking from the tube, or even a rupture of the tube, you will get blood clot, often around the sac itself. And that is known as, this would be a hemoperitoneum with clot surrounding a tubal ring. Clot can be very difficult to see, and a lot of people don't really look hard for it. They just may assume you're dealing with bowel. But here is another example of an ectopic tubal ring surrounded by a large blood clot. Look for the blood clot. It is really your friend, and it helps you to find ectopic pregnancies. So getting back to the case where we see what looks like a sac, and it's right next to the ovary. Let's say I couldn't find a yolk sac in here, and I wanted to know, is this a corpus luteum at the edge of the ovary, or is this an ectopic in the tube next to the ovary? What can I do? Well, you can take your probe here. There's a vaginal scan. Take your probe and see if you can push and separate these two structures, because if you can do that, then you're clearly going to say that this being separate from the ovary would be in the tube. So when you have these cases, and this is not uncommon, you want to push with the probe to see if you can separate the ovary from the questionable area, using ultrasound almost as you would do a bimanual clinical exam. So you're applying a physical exam using the ultrasound probe. And as we do that here, you just push down rather firmly to see if you can show independent motion of the ovary from the area in question. And if you can, as in this case, you would conclude that this is an ectopic pregnancy. Here's another example where we had the same question, and when we pushed here, we were not able to separate the ovary from the area in question. We looked hard to see if there was any other evidence of a corpus luteum elsewhere. There was not, and we concluded, therefore, that this is just at the edge of the ovary, being a corpus luteum associated with a pregnancy. Sometimes you see something and it's not exactly, doesn't really look like a gestational sac, but it's right at the edge of the ovary again. And there's a little bit of free fluid surrounding this. And when we pushed in this case, because you might question, could that be bowel? But when we pushed in this case, you can see again independent motion of this structure from the ovary. And bowel, if you pushed against bowel, would collapse because of the pressure. This is not collapsing. Here is bowel. You can see some air in bowel surrounding this structure. And furthermore, if I turned on this 90 degrees, you would see it was more or less a tubular shape. So what this represents is an ectopic pregnancy, separate from the ovary. It's the tube containing all this echogenic material, which most likely is due to a blood clot within the tube. If you put color on here and you see that some of the area has flow in it, that could be developing tissue or trophoblastic material within the tube. But this maneuver is a very, very effective one to help you decide if you're dealing with an ectopic pregnancy, as we were able to conclude in this case. Now here again, looking around carefully, we see some free fluid, but look very carefully to see if you have heterogeneous or homogeneous echogenic material that doesn't look like bowel. Because again, in this case, this is a large blood clot. It's very easy to miss and overlook, but if you see a large amount of blood, always look carefully to see if you can suggest this is clot. And also always look above the uterus and even up into the flanks. I have a rule in our lab that whenever the question is to rule out an ectopic and I don't see an intrauterine pregnancy, make sure you look by the kidneys in the flanks. You can end up with a large hemoperitoneum, and if you don't look up high, you may miss the fact that the whole abdomen is filled with a large amount of blood. Every time there is a blood clot, you are going to see free fluid above the blood clot, and a clue that you're dealing with blood, of course, is to see if the fluid is echogenic. Now, if I turn my settings up on my machine, I can put echoes artifactually into any fluid collection, and you might think if you are dealing with echogenic fluid that you're dealing with blood, but it may be artifactual. So what do you do to prove if this is really echogenic fluid as opposed to artifact? You can take the probe and push against it. And when you do, as in this case, I hope you can appreciate these echoes are spinning. And if these echoes are spinning, then you're dealing with actual echogenic fluid, not artifactually echogenic fluid, but true echogenic fluid, proteinaceous fluid, with the appropriate history, as in this case would be blood. So with respect to fluid and blood in people query ectopics, most women who have an ectopic will have some blood in their pelvis. It's important to realize this does not imply tubal rupture. I don't believe there's any way you can use ultrasound to suggest tubal rupture per se. You can have a large hemoperitoneum due to leaking fluid or leaking blood from the end of the tube. And it's also important to realize that 20% of women who have early IUPs have fluid in their pelvis, a small amount. What you want to look for is echogenic fluid, because that implies blood. And this was just a study published a number of years ago showing that if you looked at any fluid versus echogenic fluid in women with ectopic pregnancy, you can increase the specificity and positive predictive value from the 60s to the 90s. So I urge you to look specifically for clot and also echogenic fluid above the clot, and make sure it's real and not artifactual by pushing against it to see the echoes spinning. And I'll urge you again to look carefully for clot because it's very easy to overlook. Here is a woman who was at risk for an ectopic. An intrauterine pregnancy is not seen. This was done by one of our residents, and he missed the fact that there is a large amount of blood clot in the pelvis because he didn't have a whole lot of experience, and it's very easy to overlook this kind of clot. But he knew enough to look up higher, and when he looked up high in this woman in the flanks, clearly he would not have missed that echogenic fluid. But just looking in the pelvis per se, he could overlook a large hemoperitoneum, and this was a ruptured ectopic. So if we look at the criteria that we have been discussing from the strictest to the more liberal, as we go from strict to liberal, we are increasing our sensitivity and our negative predictive value as we go from our strictest to more liberal criteria. We're not really changing our specificity and positive predictive value. And this is all very good because what this tells me is that I can use all the criteria, starting with the strictest, going down to the more liberal criteria, and still be able to make the diagnosis of ectopic pregnancy with assuredness, even though I don't always see an ectopic sac, I don't always see a heartbeat, and so forth. Just seeing an extra ovarian mass that's not a para-ovarian cyst or a paratubal cyst in the appropriate patient allows me to make the diagnosis. Now, what about using Doppler flow? The idea and the rationale is to look for flow in developing trophoblastic or ectopic tissue, developing placental tissue outside the ovary. Now, people have talked about this by suggesting we look for the ring of fire, meaning you turn on your color Doppler and you see a ring-like structure and it is surrounded by bright echoes of flow. And you can see two examples here of what looks like a ring of fire. The problem is that if you look at this one, the location of this was clearly in the ovary, in the left ovary in this case. In this patient, it was not in the ovary, it was next to the ovary in an ectopic pregnancy. So I honestly am not a fan of just turning on Doppler and looking for a ring of fire. To me, it is where is that flow located, because all corpus luteal cysts should have blood flow in the periphery of them. And therefore, just looking for flow is not going to tell you that that's an ectopic. It's the location where that structure is located that helps me. So I'm not a big believer in just turning on Doppler. Furthermore, as an example here, we see a ring-like structure. It is in a tubular structure filled with heterogeneous echogenic material that would be in a dilated fallopian tube with blood. Here is some free fluid around that tube, and yet there is no flow around this structure. Does that make me conclude this is not an ectopic pregnancy? Clearly, this is an ectopic pregnancy, but it may not be alive, and therefore I may not be seeing flow within the wall of the ectopic pregnancy. So it may not be developing trophoblastic tissue, but clearly there is an ectopic in this case. So lack of flow does not exclude an ectopic. Some people suggest that we look in the uterus at the flow patterns. Sometimes there are small amounts of fluid, so-called pseudo-gestational sacs associated with an ectopic pregnancy, perhaps 10 or 15% of the time. When there's an ectopic, there may be a little flow, as we've already mentioned, in the uterine cavity. Well, if you put flow in that uterus and you see flow around that fluid collection, you might suggest that this is a patient who has an early intrauterine pregnancy, normal or abnormal, with developing tissue around it, and lack of flow around that fluid collection would suggest that this would be a pseudosac with an ectopic pregnancy. So that might be something to consider. Lack of flow, as in this case, this was an ectopic with fluid in the uterine cavity. But the problem here is that absent flow might occur with an abnormal intrauterine pregnancy. So the lack of flow doesn't exclude that, and you might have a pregnancy in the uterus with lack of flow. Another problem is the Doppler energy that we use is higher than using grayscale technology. And if there's any time when you want to avoid using energy, it's at a very, very early stage in gestation. And unless you have a good reason to turn color and Doppler and power Doppler on, I would suggest you consider omitting it altogether. And in our lab, our suggestion is, in the first trimester, not to use Doppler to evaluate for whether or not there is a sac present. Now, we've talked about pregnancies in the typical location, the ampullary portion of the tube, and that's what most women have. But I think we need to consider some other locations: the isthmic, ovarian pregnancy, the interstitial, cervical, and even abdominal pregnancies. And these unusual pregnancies go up in patients who have had assisted reproduction technology, the IVF patients and other forms of assisted reproduction to get pregnant. Ovarian and abdominal pregnancies go up from about 0.15 to maybe almost 5%. Interstitial pregnancies that occur in the portion of the tube that's traversing the upper myometrium go up from maybe 2% to about 7%. Cervical ectopics, clearly under 1%, go up tenfold to perhaps 1.5%. And heterotopics, that's a concurrent intra and extrauterine pregnancy, we said 1 in 7,000. In the typical patient who gets is pregnant is basically 1 in 7,000, so that's 0%, goes up to 3%. So in a woman who is undergoing assisted reproduction therapy, we have to look harder and further afield. So let's now look at some of these pregnancies. The interstitial, or some people call this cornual ectopic, is one that occurs in the portion of the tube that is traversing the upper myometrium, so that pregnancy is not developing in the central portion of the endometrium. And this kind of pregnancy is a real problem because it is surrounded by a certain amount of muscular tissue. Therefore, it can grow larger than a typical tubal pregnancy. And there is a branch of the uterine artery that traverses this portion of the myometrium. It comes in with the tube. And since this is larger, that vessel gets bigger. And when these pregnancies rupture, it is a catastrophe because they take that large branch of the uterine artery with it. This is by far the #1 cause of maternal mortality in the first trimester of pregnancy, rupturing a cornual or interstitial ectopic pregnancy. So how do we make the diagnosis? Well, one thing we can do is look to see if we have a little bit of the endometrial cavity, as we can see, coming up to the edge of that sac. That's been called the interstitial line sign. You can see it nicely in this scan. Another thing we can look for is the location of this sac. Notice this is high up in the uterus. It's toward the fundus. That's where the tube comes in. So we can clearly see on this 3D image, and this is a very nice use for 3D, that it is located in the fundus. Even if you do not have 3D, you can pan through the uterus and realize these implantations are high up in the fundus and surrounded by a small amount of tissue, as we can see here. So very important to make that diagnosis of the interstitial ectopic pregnancy because of the associated maternal morbidity and mortality, and they will present later often because they don't rupture that early as a tubal ectopic might. So be aware of these pregnancies. Now here we have a case where there's a pregnancy both in and extrauterine, a heterotopic pregnancy, and in this case you can see a heartbeat in each of the embryos. And we will talk about how we address this in just a few minutes. Here we have a fluid collection in the cervix, and if you look carefully, there is a small yolk sac down here. Well, what would the diagnosis be? The differential would lie between, could this be a patient who is miscarrying and has the pregnancy at this point in time in the cervix, or is this a cervical ectopic? So partly it depends upon the clinical situation. Patients who present with cervical ectopics, at least in our experience, are usually not symptomatic. Patients who are miscarrying certainly are symptomatic, and of course if you have an earlier scan showing the implantation was within the uterus and is now at the cervical level, it's easy to make the diagnosis. But you have to look at the clinical picture. In this case, this patient had a cervical ectopic. She was not symptomatic at this point. I just also want to alert you to the fact, be aware if you don't see a yolk sac and you just see what looks like a large structure here surrounded by echoes, you could be dealing with a large Nabothian cyst. Again, old scans are very helpful if you're uncertain if it's a Nabothian cyst versus a cervical ectopic. I suggest you again get serial HCG, rescan the patient a couple of days to see if you can see a developing yolk sac. So here we have a challenge case. This is unusual. Again, a fluid collection at the cervix. There is a yolk sac here. You can see it in the coronal scan better, and there is actually a heartbeat, although it is a slow heartbeat. So the differential again is an abortion in progress versus a cervical ectopic. Well, we actually thought that this was going to be a cervical ectopic. This patient was scanned up in the emergency room. We brought her down to look at her, and we were going to inject this with potassium chloride. By the time we got around to looking at her, she came to ultrasound, and this was maybe an hour or so later. It was gone, and this was a patient who had a spontaneous abortion. And even though this is uncommon to having a living pregnancy at the level of the cervix during the process of miscarrying, it can actually occur. You can have a heartbeat that is in this pregnancy, which clearly no longer has a blood supply, but the heartbeat can clearly go on for, I don't know exactly what the period of time is, and you may, in a rare situation, be dealing with a heart beating in the cervix, which would lead you to think that this is a cervical ectopic when you're actually dealing with a spontaneous abortion. Here's a case where we can look at the ovary, and if you look carefully within this ovary, there is clearly an embryo with a living heartbeat, but that is an unusual situation, an ovarian ectopic pregnancy. So now we've looked at a variety of ectopic pregnancies. How do we manage pregnancies that are ectopic? Well, in the United States, it used to be laparotomy, but today laparoscopy is still the most common way to treat ectopic pregnancies. But we also have a variety of other therapies, including non-laparoscopic medical therapy. By that I mean potassium chloride injected into the sac, methotrexate injected into the sac or injected intramuscularly, or even to observe women who are clinically stable, whose HCG is not going up, who doesn't have a lot of color flow within the ectopic pregnancy, all suggesting that it is a non-viable ectopic pregnancy. So we have guidelines, and these are only guidelines, and you have to look at, of course, the patient as well. What is the number of the HCG level? If it's fairly low, the tubal mass is fairly small, although I think these numbers from the literature are rather high and rather large. Of course, if you're not going to operate on a patient, you have to have a clinically stable patient. The literature debates whether or not cardiac activity should, yes or no, be present. When I was at the Brigham, where we did see a lot of these patients and we treated them medically, many of them had heartbeats. You have to have a secure diagnosis without having to deal with a laparoscopic confirmation. And if you treat the patient with methotrexate, you have to have no contraindication to administering it. That means a patient whose liver is functioning well. As I said, methotrexate can be given intramuscularly or into the sac. Potassium chloride can also be used directly into the sac. one of the differences between these therapies, injecting potassium chloride, particularly if you can inject it directly into the embryo, ideally into the heart, will stop the development of that pregnancy instantaneously. Methotrexate takes time. It has to get into the developing cascade of DNA. It acts like an anti-folate, and so it has to be used when in a developing embryo, and it will take days for it to work. It's not instantaneous, but it does stop the development of trophoblastic tissue or placental tissue around a sac. So sometimes we use potassium chloride into the sac and methotrexate as well to try to prevent the development of the continuous growth of trophoblastic tissue. So let's look at some examples. Here is an unfortunate woman. She's IVF, so she desperately wants to be pregnant. She has an intrauterine as well as an extrauterine pregnancy, and the extrauterine, well, it's not really extrauterine. This pregnancy is an interstitial ectopic pregnancy. How are you going to handle this situation? Because if this continued to grow and rupture, this woman is at high risk to lose her life. Notice we are high up in the uterus here because that's where this is in the fundus. This is more or less an oblique scan to show you this is actually in the lower part of the uterus, higher part where we're dealing with the cornua. So since we're high up, it's attractive to think that we could inject this transabdominally. Would be hard to reach from a vaginal approach. And this is Dr. Tubal who actually did this, injecting this cornual ectopic and terminating the cornual ectopic without affecting the intrauterine pregnancy because he's using potassium chloride here. If he used methotrexate here, he would affect both pregnancies. So you never want to use methotrexate in a situation where you're dealing with a heterotopic ectopic pregnancy. Here's another situation, 2 pregnancies, vaginal scan, and both of these have a heartbeat. Now, let's address this pregnancy in the lower aspect of the uterus. Where is it located? Well, it's in the upper cervix, and actually it's in the tissue of the cervix. It's in the anterior portion of the tissue of the cervix. If you ask the patient's history, I'm sure many of you are already suspicious. The location of this would suggest it's in a cesarean section scar. So how do you handle this? She's got a pregnancy in a C-section scar, and she's got an intrauterine pregnancy, both of which are alive. So what was done in this case was using the vaginal probe, since it's right in front of where the vaginal probe is located, Mary Frates actually injected this pregnancy with potassium chloride, and you can see the administration here of the potassium chloride into this sac that's located in a C-section scar, and the pregnancy was terminated as a result of that procedure, whereas the pregnancy in the uterus here continues to have a heartbeat and continued to grow. Looking at the lower uterine segment, that pregnancy slowly resorbed, and this resulted in a very, very good outcome where the intrauterine pregnancy was delivered. Not only that, this woman experienced a subsequent pregnancy as well. So this is a win-win situation, whereas without that administration of the potassium chloride to terminate the cervical, the pregnancy at the level of the cervix and the C-section scar, she likely would have lost her uterus. Here's just a third example where we can see again, this is a C-section scar pregnancy, and I'm showing you this to show a variety of ways to treat this. Here, there is a living pregnancy again in a C-section, and the clinician at this point, instead of injecting this with potassium chloride, elected to do a careful D&C using ultrasound guidance through a fluid-filled distended bladder, and we were able to guide the clinician as she did a gentle D&C to remove the sac in this manner. So that was successfully accomplished within 15 minutes. So there are a variety of approaches we can use using ultrasound to help us to terminate these unusual pregnancies. Now, just to end, if you look at the ectopic rate, and this is in the United States, the ectopic rate slowly has increased. This chart shows you to about 1990. The number of hospital admissions was continuing to increase to that point, and fortunately, the maternal death rate, and this is thanks to good pregnancy tests and good ultrasound, has gone way down over the period from about 1970 to 1990. Now, you might ask yourself, why am I terminating this graph at 1990? Well, the reason is it's harder to get statistics because the number of hospital admissions has gone down. Well, why is that? Well, because the number of ectopics, we believe, has gone way up and continues to go up, but since these patients are now being treated as outpatients, it's much harder to get good statistics. We don't think the number of ectopics have gone down. We know the number has gone up, but it's a real win-win situation when now we know we can deal with ectopics as an outpatient and actually treat these women as outpatients, and that is an economically very rewarding experience. So I think and I hope that the past few minutes has allowed you to look at a number of ectopic pregnancies, not only how we go about making the diagnosis, especially using the physical exam, using that probe to push and to confidently show that that suspicious tubal structure is separate from the ovary, and in addition to making the diagnosis, to understand the variety of therapies we have and how we go about using those therapies, often with ultrasound assistance.
My name is Mary Frades. I'm from Brigham and Women's Hospital in Boston. My topic today is update on ectopic pregnancy. Let's talk about some background for ectopic pregnancy. Ectopic pregnancy essentially means that the products of conception have implanted outside of the endometrial cavity. This occurs in about 1.5% to 2% of all pregnancies. We care about ectopic pregnancy because complications of ectopics are the leading cause of pregnancy-related deaths during the first trimester in the United States. The majority of ectopic pregnancies occur in the fallopian tube. The ampullary portion of the tube is the most common site, with the isthmic section the second most common. Ectopics in the interstitial portion of the fallopian tube, the so-called cornual ectopics, cervical ectopics, ovarian ectopics, pretty rare. Who's at high risk for ectopic pregnancy? Well, the known risk factors are anyone with tubal scarring. So that's a patient who's had pelvic inflammatory disease or a prior ectopic pregnancy. Any patient with an IUD present in the endometrial cavity, and also the huge number of patients who are undergoing assisted fertilization for whatever reason. For the uterus or the tubes or the ovaries are not working completely normally, and those patients will be at increased risk for ectopic pregnancy. Now, it's interesting to remember that 25% of pregnancies that occur in patients with an indwelling IUD or a history of tubal ligation are ectopic pregnancies. So when you have a positive pregnancy test in that population, you want to be aware that they are high risk for ectopics. However, even knowing that, 50% of the patients with ectopic pregnancy comes in with no known risk factor. Here's what we're talking about when I say that patients with PID or scarring are at increased risk. So here's the hydrosalpinx. You can see the dilated fallopian tube. Here's the sausage shape or the curved fluid-filled dilated fallopian tube, and the cogwheel appearance and a coronal image, a transverse image of the fallopian tube, all abnormal tubes. The classic presentation of a patient with ectopic pregnancy is pain, vaginal bleeding, and an adnexal mass. In a patient who presents with those findings, if there's a positive pregnancy test as well, ultrasound should be the first test done. And here we see tubal ring sitting right next to the left ovary. Let's talk about HCG. So trophoblastic tissue makes HCG 8 days after conception. Normally, an intrauterine gestational sac will typically be seen with transvaginal sonography once that HCG gets to 1,000 milli-international units. However, you should be aware that in a study done in 1997, 1/3 of the patients with HCGs of over 2,000 ended up with intrauterine pregnancies at follow-up. So from some data from our hospital at Brigham and Women's, we looked at 225 patients with ectopic pregnancies, all of whom had their HCG drawn within 24 hours of the transvaginal ultrasound. The HCG in this patient series ranged from a low of 7 to a high of 107,000, the average being around 3,000. It was significantly higher in patients with a live ectopic pregnancy, 20,980, as opposed to patients whose ectopics did not have cardiac activity, where the average was 1,900. The majority of the patients in our series did have an HCG of under 3,000, but 7% had an HCG of over 10,000. I'd like to just mention a cautionary case that we did see recently at the Brigham, where a patient came in with an HCG of over 4,000, and at transvaginal sonography, nothing was found in the uterus. In addition, nothing was found in the adnexa. We followed that patient up, and she ended up with a normal intrauterine pregnancy. So it is incredibly important to realize that patients should not be treated for an ectopic pregnancy unless you are absolutely certain that there is nothing in the uterus that could potentially be a normal intrauterine pregnancy. When you have a patient with a positive pregnancy test and no pregnancy is found in the uterus on transvaginal sonography, we term that a pregnancy of unknown location. And in this situation, there really are only 3 options. Either the pregnancy is in the uterus and it's too early or too small for us to identify with transvaginal sonography. The patient could potentially have just undergone a spontaneous loss or have a chemical pregnancy, or there may be an ectopic pregnancy. So how do you know whether there's an intrauterine pregnancy or not? Well, an intrauterine pregnancy, an intrauterine gestational sac, is round, has a very clear echogenic rim, and often will have a yolk sac, a fetal pole, or a fetal heartbeat. It should be located within the decidua of the endometrium. Don't be misled by fluid in the endometrial cavity. Here's a few examples of small gestational sacs. On the top left, you see a well-defined echogenic ring with a little bit of free fluid in the endometrial cavity, and you can appreciate, I think, the intradecidual location of this gestational sac. Bottom left image, again, a little tiny fluid collection within the decidualized endometrium, maybe too small to know for sure whether that's a gestational sac or not. And on the clip, you can see a little bit of a bigger fluid collection with a white ring in the decidualized endometrium. These can either be dictated as a small early gestational sac or as a probable gestational sac. Another case, clearly defined echogenic rim, round sac in the decidualized endometrium, and some fluid in the endometrial cavity, or likely blood. In comparison to these 3 cases, we can see that there's fluid in the endometrial cavity, very irregular, poorly defined, a little bit of debris in this one, but not a discrete, well-defined circular structure with an echogenic rim. In these cases, no gestational sac is seen. Some complex endometrial fluid is present. When we look at the endometrium in a patient that we're concerned about the presence of an ectopic or an intrauterine pregnancy, well, one of the things we can look at is how thick the endometrium is. Is this a reasonable thing to do? Well, in 2008, one author showed that if the endometrium was less than 8 millimeters in thickness, none of those patients had an intrauterine pregnancy. At the opposite end, in the patients with an endometrium over 25 millimeters, 4 patients with ectopics did have that very thick endometrium. Can we look at a trilaminar pattern, the multi-layered endometrium? Will that help? When we use a multi-layered endometrium with an attempt to predict whether there's an ectopic pregnancy or not, it has a very low sensitivity and a positive predictive value of only 50%, so flipping a coin. So trilaminar pattern, not that useful. Here's a patient who was seen recently on Clomid by her last menstrual period. She should be 7.5 weeks. And when we look transvaginally, this was no intrauterine pregnancy is seen. Here's the image that was submitted to us as a normal right ovary. This was done at one of our remote sites. But at 7.5 weeks, we were concerned that there had to be a pregnancy in there somewhere. So she had the exam repeated that afternoon at the hospital, and here's the right ovary image that was then obtained. You can see that the right ovary with its corpus luteal cyst is here, and that there's a complex mass seen on the lateral edge of the ovary. And with a video clip, we can appreciate that there is an embryo with cardiac activity seen in this ectopic sitting right next to the ovary. So you do have to be careful. Just one picture of an ovary does not rule out the presence of an associated mass. Again, it's more important to identify a mass in the adnexa, and that's the best way to diagnose an ectopic pregnancy, rather than relying on the fact that there's nothing in the uterus. The earlier we can find a mass, the earlier we can take care of the patient. So unlike the traditional non-pregnant patient where you scan the uterus and you take a coronal and a sag clip of one ovary and a coronal and a sag look at the other ovary, that's when the study starts for ectopic pregnancy. You can do your standard exam, and then you have to start looking around for anything out of the ordinary that could be the ectopic. It's not going to be one of the traditional pictures that you're taking for your pelvic ultrasound. Here's a patient who had a history of ectopic pregnancy who came in with her dating at 4.7 weeks with some pain and highly concerned because of her prior history. And we could see, here's an image of the ovary, but just next to the ovary, we could see a soft tissue structure with blood flow just lateral to the ovary. And on the video clip, you can see the ovary is here, and there's this structure, which was a tubular, solid appearing structure just lateral to the ovary. This turned out to be normal fallopian tube in this particular patient, and on follow-up, there was a normal intrauterine pregnancy. So if the patient is stable and the findings are not convincing, the best thing to do is follow the patient, follow the HCG, and get a repeat ultrasound. What are we looking for in the adnexa? Well, the most convincing finding for an ectopic pregnancy is the presence of a tubal ring. A tubal ring is a round hypoechoic or anechoic structure with an echogenic ring around it, which is basically the gestational sac. You can think about the sac that we looked at, or early sacs that we looked at in the uterus, picking up that sac and moving it out into the adnexa and throwing it over there next to an ovary or next to the outside of the uterus. It's the same look. You're looking for a pregnancy sac. 25% of patients with ectopic pregnancy in our recent series did have a tubal ring. 8% had a tubal ring with a yolk sac, and 7% had a tubal ring with a yolk sac and cardiac activity. What does the tubal ring look like? Well, here's another patient with ectopic pregnancy. We can see the ovary here with a corpus luteal cyst on it, and the bright echogenic ring with an anechoic center. Here's the yolk sac, and when we look closely, we can see an embryo and cardiac activity in this live ectopic. Here's another patient. This is a coronal image of the uterus, and you can see a beautiful intrauterine gestational sac, pretty much anechoic center, echogenic ring around the outside, and a yolk sac in the middle. But look at this, out in the left adnexa is the identical picture. Here's the echogenic ring, the anechoic center, and the yolk sac. And this patient has a heterotopic pregnancy with an IUP and a left-sided ectopic pregnancy. But it's amazing how similar the two pregnancies look. Sometimes the findings are pretty subtle. In this patient, here's the left ovary, and you can see there's a little tiny echogenic structure. Well, it got an anechoic center and an echogenic ring around the outside. Here it is measured, and here it is in the sagittal plane. It looks a little bit bigger the ovaries up here, a very bright echogenic ring helps us know that this is a tiny early ectopic. Sometimes we don't see the echogenic ring and we just find a complex mass with poorly defined borders, very ill-defined. Over half of ectopic pregnancies in our series presented with this finding. When you see these ill-defined complex masses, take a really close look in the center of the mass because you may be able to find the tubal ring or a yolk sac or something that tells you that this indeed is an ectopic pregnancy with a large amount of clot around it. And if this complex mass is tubular, remember that you're likely looking at a hematosalpinx or a fallopian tube that has filled up with blood due to the central ectopic pregnancy within the tube. Here's what I mean by a heterogeneous mass. This is a patient who's at 5.7 weeks based on IVF. Here's the ovary, here's the edge of the uterus, and we can see this solid, nondescript, hypoechoic mass separate from the ovary, separate from the uterus, 2 centimeter mass. This is the ectopic pregnancy. In a different patient, we can see the ovary here and this tubular, somewhat echogenic structure in the adnexa. And if you look closely at this tubular hematosalpinx, you might appreciate that there's a little echogenic ring, almost like a donut, right in the middle of the structure. And when we zoom up on that adnexal ring, we can actually see that there are 2 gestational sacs, and this is a twin ectopic pregnancy out in that fallopian tube. This is an old case, but really illustrates what we're looking at very well. On the sagittal image in the adnexa, we can see the echogenic ring of our adnexal ring within this larger heterogeneous mass. And on that coronal image, you can see that this is actually the wall of the fallopian tube. Here's the gestational sac that's grown into the wall or attached to the wall of the tube. There's a little bit of bleeding inside the tube, giving you the hematosalpinx, and also blood that has gone out the end of the tube is now in the peritoneal cavity, outlining the outside of the hematosalpinx. So what really are we looking at? What are we looking for in the adnexa? Well, there's a well-known paper in Journal of Ultrasound and Medicine in 1994, which is a meta-analysis of 10 studies. And in that meta-analysis, the authors found that the most appropriate criteria for diagnosing an ectopic pregnancy is any non-cystic extra-ovarian adnexal mass. So think about that. The mass cannot be on the ovary, so anything not on the ovary, but it also can't be a cyst. So it cannot be the typical simple para-ovarian cysts that we see all the time. Crossing off the cystic structures, crossing off anything in the ovary. If there's anything else left in the adnexa, that's the ectopic pregnancy. And when you look at these non-cystic adnexal masses, there's a sensitivity reported of almost 99% and a positive predictive value of 96%. This study was re-looked at in 2005, and the numbers, if anything, are better. Almost 100% sensitivity, positive predictive value, again, well over 93%, and a negative predictive value of almost 100%. So here's another example of an ectopic pregnancy. The ovary is here, and there's a big mass here which is very echogenic, ill-defined, doesn't really look like a gestational sac, but it certainly is a mass in the adnexa. It's not a simple cyst, it's not on the ovary. You can see we're pushing on it here. It's very ill-defined, it doesn't have a lot of information, pretty close to the ovary, a little bit of free fluid, and a video clip through the mass showing the ovary here. But look closely at this mass. Look very closely. Watch the whole clip. Right at the end of the clip is this. Here's the tubal pregnancy right here. And if you look at it, I'll put my arrow right on it. It's right there. There, right at the end. There's a little tiny sac in the middle of this enormous clot. So look carefully when you see these big masses. Sometimes your answer is right in the center. In comparison, in this other patient with ectopic pregnancy, we do again see an echogenic lesion in the left adnexa. And on this clip, you can see that there really is nothing within it. And this is just a collection of trophoblastic tissue, that bright echogenic trophoblastic tissue in the hematosalpinx, and free fluid with echoes around the lesion. So less specific, but just as suspicious for the ectopic pregnancy. So things to think about when you're looking at the adnexa and you find a mass. One question is this mass part of the ovary or not? And that's a useful thing to help you decide whether you are concerned about an ectopic. But also look at the mass and determine what the echotexture of the mass is. So what do I mean by movement of the mass? Well, if you, during a transvaginal scan, place some pressure on the patient's anterior abdominal wall as the vaginal probe is on your lesion and push, you can see here that the ovary stays lateral and the ectopic pregnancy slides away and slides medially. So this shows us that this lesion is not part of the ovary. It moves separately from the ovary. In comparison, this patient who has a complex lesion on the medial edge of the ovary, when we push, the lesion sticks with the ovary. It all stays together. We cannot separate this off the ovary, and that's because this is the corpus luteum, not an ectopic. When you look at movement of an adnexal mass, the majority of patients with ectopic pregnancy did show movement of a mass with palpation. A few patients without ectopics also showed movement of the mass with palpation. Potentially that was some hematoma or some normal fallopian tube that can slide away from the mass. So that is a reasonable thing to do to help you determine whether the lesion is part of the ovary or not. Here's a patient with an empty uterus, no intrauterine gestational sac. Here's the ovary, so we do see a mass next to the ovary. And again, when we use pressure, you can see that the ovary slides, but this adnexal mass rolls. It would be impossible for a cyst, a corpus luteal cyst on the ovary, to turn or roll. So that motion, even though we're not really separating them, we can see the mass move whereas the ovary slides away. So that confirms our suspicion of an adnexal mass and an ectopic pregnancy. Here's a patient who came in a few years back with persistent abdominal pain, having undergone IVF. And she was told at an outside hospital that she had an intrauterine pregnancy, and indeed we do see an intrauterine pregnancy with at least one yolk sac, potentially 2 yolk sacs, but she's still having pain, and notice there's quite a bit of free fluid over on the right side of her pelvis. So out in the right adnexa, she had an enormous heterogeneous, complex mass. This is where all her pain was. And looking at the mass, I was able to appreciate, I thought, well, let me see if I can find the ovary inside this mass. Is this just the ovary that has a hemorrhagic corpus luteal cyst, or is this a problem? And inside the mass, I could see this hypoechoic ring and an echogenic ring, both. Turning on the color, you can see color flow here around the patient's corpus luteum. This is the right ovary, and right next to the ovary, an echogenic ring, also with a little bit of blood flow, and this is her heterotopic pregnancy, creating a lot of clot around the right ovary. Well, when we are trying to figure out whether we're looking at a tubal ring or a corpus luteum, we did do a study a few years ago looking at the echogenicity of the tubal ring in comparison to the echogenicity of a corpus luteum. We had 26 patients in that series who had a tubal ring with a yolk sac or with a heartbeat. And of those 26 patients, 88% of the rings were brighter or more echogenic than the ovary. We also had 13 patients with empty rings, no yolk sac, no heartbeat, no way of knowing whether this was truly an ectopic, and yet 77% of those patients, the ring was more echogenic than the ovary. We had a control group of 45 patients with a normal intrauterine pregnancy and no ectopic, and in those patients, the corpus luteum was more echogenic than the ovary in only 3%. So the vast majority of corpus luteums are isoechoic or hypoechoic. The vast majority of ectopics are echogenic. This is what I mean. These are patients from our series. Here's the ovary here, and here's the echogenic tubal ring. And you can see that the wall or this ring is clearly much brighter than the parenchyma of the ovary. In comparison, here's the thick-walled corpus luteum, hypoechoic in relationship to the echogenic ovarian parenchyma. So the relative echogenicity of an adnexa ring can be a very useful characteristic if you can't figure out based on location whether you're looking at a tubal ring or a corpus luteum. Another paper looked at this where they compared the echogenicity of the ectopic and the corpus luteum to the endometrial stripe. And in this study, they found that the wall of the tubal ring or of the ectopic was brighter than the endometrium in 30% of the ectopics, but none of the corpus luteal cysts. The wall of the lesion was less echogenic than the endometrium in a third of ectopics, but in the majority of the corpus luteal cysts. Here's a patient that was seen overnight a few years back, and one of our residents took this transvaginal image showing an intrauterine pregnancy. There's a yolk sac and there's a heartbeat of 106. And out in the adnexa, here's the right ovary, and they found this lesion out in the right adnexa with an echogenic ring around it, brighter than the ovarian parenchyma. The resident was very concerned that this was an ectopic pregnancy, and the patient was taken to the OR. Well, there's a couple problems with that scenario. One is if we look closely at this echogenic lesion, we can see that the ovary itself goes all the way around the echogenic lesion, and this is clearly an intra-ovarian cyst, not a non-ovarian lesion. So that's one reason why we shouldn't be concerned about an ectopic. Number two, the patient has an IUP, so they're less likely to have an ectopic pregnancy. Number three, or the third problem with this case, is that the patient went to the operating room even with a completely stable clinical picture, no free fluid, normal blood pressure. This patient probably should have been watched rather than taken to the OR emergently in the middle of the night. And this is what happened when they got to the OR. Here's the lesion. You can see that this is the ovary here, and this lesion is clearly intra-ovarian, and it was simply the corpus luteum, and here's the uterus here. Now, this patient did fine, and the intrauterine pregnancy continued normally, and the gynecologists were clearly did not remove the corpus luteum, and that just closed up and the patient went home. But it's important to remember to use the echogenicity and the location of the lesion, not one over the other. Now, when we're looking at a tubal ring versus a corpus luteum, what about Doppler? Can we do Doppler of the lesion and help us distinguish between an ectopic pregnancy or a corpus luteum? Well, the resistive index around an ectopic pregnancy is widely variable and can go from 0.1 to 1.6. That's a huge span, as opposed to the corpus luteal resistive index, which is much lower, somewhere between 0.39 and 0.7. So it did show us that an RI of greater than 0.7 was 100% specific and had a positive predictive value of 100%. But that's not that useful because only 1/3 of the ectopics in this study did have an RI that was that high. Well, here's another finding we can look for in the adnexa. What about the presence of free fluid? What's important when we look at fluid in the cul-de-sac in a patient at risk for ectopic pregnancy to determine whether there are echoes in the fluid or whether the fluid is anechoic. The reason is that when there are echoes in the intraperitoneal fluid, there's a very high correlation with hemoperitoneum. And that suggests to us that this patient is at very high risk for an ectopic pregnancy. And this is an old paper from 1991, but has stood the test of time. In 1998, an article in JUM looked at 185 patients who were taken to the operating room for ectopic pregnancy. In those patients, 125 of the patients had echogenic fluid at the time of the ultrasound, and over 98% of the patients, blood was found at surgery. In the 30 patients with anechoic fluid, 0 had blood. And in the 30 patients with no fluid at transvaginal sonography, 0 had blood. So this confirms that echogenic fluid in the cul-de-sac does correlate with hemoperitoneum in patients with ectopic pregnancy with high sensitivity, specificity, and positive predictive value. In another study done in the Annals of the American Journal of Emergency Medicine, 38% of patients with pregnancy of unknown location had isolated free fluid. Of these 38 patients, 42% ended up with ectopic pregnancy. About a quarter of those had a moderate amount of fluid, and 3/4 of the patients who presented with a large amount of fluid. So it does tell us that patients with isolated cul-de-sac fluid are at a moderate risk for ectopic pregnancy. And if the fluid has echoes in it, or if there's a large amount of fluid, we're going to be more worried about those patients. Here's a patient who presented at 5.4 weeks, and out in the left adnexa we see complex fluid, ill-defined, maybe sort of clumping up here, suggesting a clot. And on the right side, a large amount of fluid with low-level internal echoes. And in this patient, this was the only finding of an ectopic pregnancy. We could not find a mass. We could not find an intrauterine pregnancy, just echogenic hemoperitoneum. What about the patients with a completely negative exam? Well, why do we miss ectopic pregnancies? It could be because the pregnancy is extremely early. If the pregnancy is under 5 weeks, these are very, very small, and it could be too early it's too early for us to see in the uterus. It could be too early for us to see in the adnexa. Patients with a high BMI, patients with a lot of fibroids, inexperience of the sonographer, or patients who have pathology in the ovaries make it difficult for us to find the ectopic pregnancy. 5% of the patients in our series had 0 findings at their pelvic ultrasound. If the patient is stable in this instance, the most important thing to remember is you haven't found an ectopic, just get follow-up ultrasounds and HCGs, because we need to make sure that that patient does not have an intrauterine pregnancy. If the patient is unstable, she has to go to the operating room, whether we've found the problem or not. Here's a patient in whom the presence of pathology in the ovary made it very difficult for us to make the correct diagnosis. This is a patient who had undergone IVF, and following the IVF had hyperstimulation. And you can see on this clip that there are very large cysts on the ovary sitting down in the cul-de-sac, and we have free fluid, again, all related to the hyperstimulation. On this video clip, I don't know if anybody has noticed anything going by, but when we look a little bit closer, you may or may not see it now. Here's the big cyst on the ovary, and here's a little complex lesion with maybe a little flicker. And here's the zoomed up image, and now it's easier to see the echogenic ring, the yolk sac, the embryo, and the heartbeat. But I will say, in view of the large cysts on this ovaries and the known hyperstimulation, we did not immediately see this, and the patient went to the OR for persistent pain. This turned out to be a primary ovarian ectopic, and we were completely thrown by all of the other pathology in the ovary and missed this little tiny ectopic sitting on the edge. What about tubal rupture? You hear a lot of conversation about tubal rupture with ectopic pregnancies or ruptured ectopics. And remember, when you talk about a ruptured ectopic, you're not talking about the gestational sac itself that has popped for some reason and the yolk sac fell out. We're talking about the fallopian tube that ruptures and with the gestational sac inside. Well, we care about it because there is an increasing trend across the world toward medical management of ectopic pregnancy. And if the patient is going to be managed non-surgically, it's very important that we know that the fallopian tube is intact. So can we help? Can transvaginal sonography tell the referring gynecologist whether the fallopian tube is intact? In our retrospective study, we had patients who had ultrasounds within 24 hours of their surgery, and all of the patients had ectopic pregnancy proven at surgery. This study was composed of 143 patients, and at the time of surgery, 75% were unruptured and 25% were found to be ruptured at pathology. When we looked at those 143 patients and we divide the ultrasound findings to whether there was a cardiac activity, a yolk sac, just a tubal ring, a generic looking mass, or no mass at all, the rupture rate in these categories was not significantly different between any of the categories. There is no statistical significance based on what the adnexal mass looked like or even whether there was a mass at all. It turned out that the rate of rupture in our series was significantly higher if the fluid was moderate to large. A third of those patients were ruptured, as compared to the patients with small or no free fluid. Only 17% of those were ruptured. However, moderate to large fluid had very poor sensitivity for tubal rupture and a very poor positive predictive value. What about HCG levels? Can we look at the HCG level and determine whether that patient has a ruptured tube? Well, we had 139 patients who had an HCG within 24 hours of their surgical confirmation of ectopic pregnancy. And it turns out that there is no cutoff level that predicts tubal rupture. And interestingly, approximately 10% of our patients with very low HCGs did have rupture of the tube at surgery. Here's two patients with very similar ectopic pregnancies. Here's the ectopic here. You see the bright echogenic ring and the central yolk sac. In this patient, the bright echogenic ring. Here's the yolk sac. These look very, very similar to me sonographically. One is ruptured and one is not. The answer is this is the ruptured ectopic. Clearly, we cannot tell the difference based on the sonographic appearance. So remember that tubal rupture is possible when we don't see a mass at all or when there's little or no free fluid. There's no single appearance that we can see at sonography to guarantee no tubal rupture. And there is no single HCG level that we can use to completely exclude a tubal rupture. So last but not least, finishing up, what about the role of 3D imaging? Well, 3D imaging can be very helpful when we're looking at the more unusual types of ectopics. In other words, cornual ectopics, tubal ectopics, or normal implantation. It's useful with cervical pregnancies and particularly useful with C-section implantations as well. So here's a patient with a retroverted uterus, and we can see this big echogenic lesion in the lower uterine segment. And because the patient is retroverted, we know that this is the site here. This is the anterior surface of the uterus. This is the site of the prior cesarean section. This is where the C-section scar is. And this pregnancy is almost certainly a cesarean section implantation. And on the video clip, we can see the pregnancy. We can see the bulge of the anterior myometrium. And with color Doppler, we can see blood flow going out, around, and extending to the surface of the uterus, that the whole placental or trophoblastic tissue has penetrated the myometrium. And on this 3D coronal reconstruction, here's the fundus of the uterus up here. The pregnancy is clearly not at the fundus. And this picture has been rotated, so this is the back of the uterus, and this is the front of the uterus. And we can see that the myometrium is completely disrupted here in the lower uterine segment, and the pregnancy sac is bulging out of the cesarean section scar. Here's a patient who came in at 5.5 weeks with a question of a C-section scar implantation. So the uterus is here, the fundus is up here, down in the cervix, and this is the region of the C-section scar, and indeed this gestational sac is quite low in the lower uterine segment. And the question is it possibly going up into this C-section scar or not? So what do? The patient's asymptomatic. We're going to follow this patient up, and here she is at 6.5 weeks, so a week later, and here's the 3D reconstruction, anterior view. You can see the pregnancy sac still in the lower uterine segment. But to really know whether the cesarean section scar is involved, we have to rotate the image so that we can look at the anterior surface of the uterus. And here's the cesarean section scar right here. And you can see that the gestational sac is seated well away from the scar. I will point out, however, that on 2D imaging, we can see the cesarean section scar right here, and the gestational sac well above the level of the scar with 2D imaging, quite clear as well. What about cornual implantations or the true interstitial pregnancies? Here's the uterus, the endometrial cavity, no gestational sac seen there, Up at the right cornua or the right fundus, we can see the pregnancy with the echogenic rim and embryo, cardiac activity, and here's the myometrium heading out and around at least one part of this pregnancy sac. Lots of color flow seen around the implantation, and when we push, we can't really separate this pregnancy from the bulk of the uterus. You can see it's certainly separate from the endometrial cavity. And on the 3D coronal reconstruction, you can see that the pregnancy is disrupting the myometrial surface at the right fundus, so it's a true interstitial or so-called cornual ectopic. Another patient with a cornual implantation, this one is a little tougher because if you notice on the video clip, the endometrial stripe is diverging. So we're looking at possibly a subseptate uterus. And in that instance, you want to be careful because you're going to have some asymmetry and the sac can be located well off to one side or another. The issue becomes whether there's myometrium all the way around the pregnancy, whether the pregnancy is still in the endometrial cavity or not. And here 3D became was very useful to us. So you can see on the reconstruction that the patient does have a subseptate uterus with a big piece of this fundal myometrium diving down into the endometrial cavity. But we can also see that at the right horn, out at the right cornua, that the endometrial cavity ends here, and the gestational sac is separate from the endometrial cavity and partially covered by a very thin myometrium. And this was a very useful time for 3D imaging when you have an anomaly of the uterus and a pregnancy not smack in the center of the endometrial cavity. In comparison to this patient, where we can see the endometrial cavity and we can see the pregnancy that is not in the endometrial cavity. And on the 3D reconstruction, here's the gestational sac sticking onto the left corner. Quite a bit of myometrium here, quite a bit of myometrium here. The question is this myometrium coming out and around? And this 3D image was actually a little bit misleading because when we pushed on this pregnancy, we could actually see that the pregnancy moved separately from the uterus. And this is an intramural ectopic pregnancy, or a pregnancy in the part of the fallopian tube very close to the uterus, but not the interstitial component of the tube, just really close by to the uterus, and just a tubal pregnancy mimicked, which mimics a cornual ectopic on the 3D imaging. So make sure that you use all of the tools at your disposal. In conclusion, transvaginal sonography continues to be the optimal method for evaluation of ectopic pregnancy. Early diagnosis of ectopics allows less invasive treatment options for our patients. It's important to do a close evaluation of the endometrium, a close evaluation of the adnexa using palpation and 3D imaging when necessary, and critically important, the stable patient with a pregnancy of unknown location, follow-up is best in that patient. Thank you very much.
Hi, I'm Deborah Rubens. I do ultrasound at the University of Rochester, and today I thought I'd bring you a talk on basically acute pelvic pain. It's on hemorrhagic cysts and torsion, and hopefully it'll help you better take care of your patients. Welcome. I thought this would be an update for people on hemorrhagic cysts and torsion. And our goals today are to certainly think about acute ovarian disorders. Obviously, I'm starting from the top. The most urgent is rupture with hemoperitoneum. And mostly today we're going to be talking about the next two, which is torsion and hemorrhage. So our objectives is to review the image appearance of hemorrhagic cysts and ovarian torsion, and I want to introduce to you the SRU Consensus Conference guidelines that were published in 2010 for the management of hemorrhagic cysts, and then we'll talk about some of the potential pitfalls in the diagnosis of hemorrhagic cysts and ovarian torsion. So just to begin, we need to review the normal ovary, and remember that we're going to have developing follicles up to 3 centimeters in size. And as the ovary goes through its normal function, we form a corpus luteum, and you can recognize that by this hypervascular rim. It's thick-walled, and it has often crenated or infolding margins, and it may or may not have internal echoes. And this is a normal functioning follicle cyst that's gone through the physiologic menstrual cycle. So again, what it looks like on CT as well as on ultrasound, this is not abnormal. This is this hypervascular rim here on CT. Same thing on ultrasound. It has a low resistance flow and this crenated margin, these infolding edges that tell you that this is a normal corpus luteum. As I said, the internal echoes can be variable, so it can be relatively anechoic, as you see over here, or it can be filled with internal echoes if there's been some hemorrhage as the patient ovulates. And as you might expect, the hemorrhage can have variable appearances as well. It can be hypoechoic, as you saw on the prior slide, but it can also be even echogenic, and sometimes you can have a clot which retracts. And again, this is a hemorrhagic echogenic corpus luteum. Notice that the patient does have some free fluid in the cul-de-sac, indicating that she has recently ovulated. So what are hemorrhagic cysts? Well, on ultrasound we define them as cysts with a thin, regular wall. There's increased through transmission. Should be no internal vascularity, and again, we can have variable patterns of internal echoes, which will change over time and ultimately resolve. And basically, this is something that's bigger than 3 centimeters that we see in the patient's ovaries as we do our transvaginal and transabdominal ultrasounds. So what are some of these internal features? Well, these are the classic ones, a lace-like or spider web septation, where you can see here these tiny, tiny, very, very thin dashes, which sometimes then can go all the way across and can sort of fill in to be a little bit more solid looking. We can also see a retractile or avascular clot, and the clue to this is, again, you have straight margins or sometimes concave margins. Here you can see a little bit of the fishnet alongside of that clot. Here the cyst is mostly filled with the clot, but again, as it retracts, as it pulls back, it has these slightly concave and straight-edged margins. If you have a completely filled cystic structure, as you see here with this increase through transmission, but it looks more solid, then you may need to watch it over time. And as you can see, this is from Dr. Scout from Yale University. Over time, this becomes more lace-like and eventually has a small amount of this retractile clot with a straight edge against the side wall. So if you have a classic hemorrhagic cyst and it's under or equal to 5 centimeters in a premenopausal woman, you do not need to follow this up. And the classic patterns are this fibrin strand pattern, this lace-like reticular pattern, or the retractile clot. If it's larger than 5 centimeters, then you should get a short interval follow-up in 6 to 12 weeks to assure that it is actually resorbing. And this was published from the SRU Consensus Conference in Radiology in 2010, and I encourage you to take a look at this because it's very valuable in terms of following up your patients. Can you have hemorrhagic cysts in early menopause? Well, yes, you can, but you want to make sure you describe them in your report. And again, with these patients, this is no longer a normal physiologic function. You want to make sure that these resolve, so do get follow-up on these patients. In late menopause, greater than 5 years after the last menstrual period, women do not ovulate, so they should not get hemorrhagic cysts, and you want to consider that these are neoplastic and manage them accordingly. The patients who are not classic, those are the ones who require more imaging. So in those patients, you want to think about patients with low-level echoes or a fishnet or a mesh appearance, a slightly thicker appearance to that lace-like pattern. If you can't tell if it's a clot or a nodule, or if the echoes are layering, there are some things you may want to consider. So we'll go through those individually. So here's a patient with diffuse low-level echoes. You can see here is one patient. This is a different patient. Here is a third patient. And these two on the left of your screen represented hemorrhagic cysts. They resolved and went away. On the right, this is slightly more attenuating, although it's avascular, and this did not go away. This came out, and this was a fibroma. Again, diffuse low-level echoes can all be hemorrhage, but they may not always be from a hemorrhagic cyst. This patient here on the left of the screen was a hemorrhagic cyst. On this one, you can see there's a slight bit of nodularity there. You can see flow around the margin of this, and this one was an endometrioma. Another example of a patient with endometrioma, again, very, very diffuse, low-level echoes here. Did not go away. She had a follow-up CT for another problem, and this was incidentally noted, still present on her CT, so endometrioma. Can we tell fishnet versus mesh? Well, here again, these fine lace-like echoes, here they are over here, but if you look carefully, sometimes you'll see some abnormal contours here on the inside of the wall. This is a mural nodule over here, and this one represents an endometrioma. Here, the MR for this patient on the right. You can see the fat fluid level. The fat certainly suppresses on the out-of-phase sequences, so this one is a teratoma. What about clot versus tumor? Well, again, always turn on the Doppler. So here is an obvious nodular appearing soft tissue collection with some what looks like septations going out from it, similar to this one. But on this one, you can see there's flow within this nodule. This one had no flow, and when it was followed, again, this resolved over time, was a retracting clot. Again, always check for flow in the septa and the nodule and follow up over time if there's any question. And again, thanks to Dr. Scout for this lovely case. And layering echoes can occur in a hemorrhagic cyst, although we don't see them that often. Here is such a case. Here's another patient who has some layering echoes, and this one happens to be an endometrioma. So again, follow-up is your clue if you can't tell the difference. What are some pitfalls we might encounter with hemorrhagic cysts? Well, here's a patient who has heterogeneous internal echoes here. You can see the uterus here. This was a young patient, so this is a transabdominal scan, normal left ovary. Here we can see that this looks like it should be a hemorrhagic cyst, and actually it is a hemorrhagic cyst, but when you image the patient where she hurts, it's actually not over that cyst. It's a little bit further down in the pelvis, and you can see a funny looking mass here in the right lower quadrant that when you measured it was 1.2 cm, and you could almost make out a gut signature. And when she was sent on to CT, you can see she has acute appendicitis with the appendix coming down into the pelvis, abutting this hemorrhagic cyst. So always image where the patient hurts, and beware that you can sometimes have more than one thing going on. What about a hemorrhagic cyst versus torsion? Certainly, cysts can act as a lead point for torsion, and this patient had a mass seen on CT, was sent to ultrasound to see about torsion, and when we actually imaged her, you can see all the echoes within this. This was a hemorrhagic cyst. We could not see any flow in this ovary, so she was sent to the OR, but it was only a hemorrhagic cyst compressing the normal ovary, and we were unable to elicit flow. This patient, however, on the other hand, is also with right lower quadrant pain, has an obvious retractile clot, but it's certainly bigger than 5 centimeters. She had a lot of pain, a lot of symptoms. There was flow in the ovary. However, the ovary was out of normal position. It was in the midline, and so she did go to the OR, and this was right ovarian torsion without ischemia. So there is overlap, and that does bring us to the next topic on our list, which is ovarian torsion. As you know, this is partial or complete rotation of the ovarian vascular pedicle. It can cause arterial, venous, or lymphatic obstruction. It's most common in our reproductive age group and often has a large cyst or neoplasm as the lead point. The most important probably is the clinical presentation, which is usually abrupt pelvic pain, nausea, and vomiting. So we have some grayscale features to look for, and these are the most important. Despite the fact that this is a vascular problem and the patient has symptoms because of vascular compromise, the grayscale is what tells us what's going on. So we're looking for a midline enlarged ovary. It can either be above the fundus or back in the cul-de-sac. We'll see this string of pearls, these peripheral cysts, these displaced follicles. You can have a coexistent mass at least half of the time, may see pre-pelvic fluid, and also look for the ovarian pedicle, a target appearing mass, the twisted fallopian tube. So let's go through these slowly. Here is an enlarged abnormal ovary, and by enlarged I mean over 5 centimeters in length. You can see the follicles are pushed peripherally, and you can see echogenic stroma centrally. Midline position, very, very important. So this is a patient, you can see here's a transvaginal probe sitting up against the uterus. This ovary is in the midline directly posterior to the uterus. Again, these displaced follicles, very large ovary. Here's another one from transverse imaging. Again, uterus here and large midline ovary, abnormal in appearance, large size, and large abnormal location. Again, here's another patient. We can see from the posterior aspect here, the uterus, here's an IUD in place. Here is the ovary, again, up in the midline and up anterior and above the uterus. So the grayscale picture is classic here. You can see here's a normal ovary, again with the follicles displaced somewhat to the periphery, but you can see normal flow certainly within the center, and this ovary is normal in size. Again, the torsed ovary has no flow, but it can also have damped flow, or as we just saw in the prior case, can look pretty normal looking flow. So what about these Doppler features? Well, if the flow is completely absent, that is considered diagnostic, but if the arterial and or venous flow are present, that does not exclude the diagnosis of torsion, and you can have arterial flow only or venous flow only, and both of those can be present with torsion. So we do want to, again, look for a whirlpool sign, which will be twisted vessels in that vascular pedicle. So just some examples of the various Doppler patterns. Here's a patient with a 3-day history of left lower quadrant pain. Not quite a classic history. The left ovary, however, is larger than the right, and the follicles are somewhat peripherally placed. You can see normal flow in this right ovary, normal follicles, normal size. Left ovary, you don't see the same flow, even with power Doppler, and absent flow. This is just noise above and below the baseline. So this ovary, unfortunately, was infarcted at surgery. She'd been obviously suffering for 3 days. Here's a patient with a very, very large cyst. Again, you can see the normal side for comparison over here, the normal waveform, but here is the abnormal enlarged grayscale appearance with these very small follicles, no normal follicles, and even though you're seeing a Doppler arterial and venous waveform, this is very abnormal. It's damped compared to the normal side, and you can see this big cyst, which was the lead point. So grayscale versus Doppler, again, even though it's a torsion question, grayscale is by far the most specific with the appropriate clinical findings. And in this recent review from Vanderbilt, they found that over half were associated with a mass. The ovary is always enlarged. Most of the ovaries here, the majority, will have arterial flow, and a third actually will have venous flow. So again, Doppler is not as helpful, although it can be supportive of your diagnosis. So a couple of quiz cases for you. Here's a transabdominal scan, patient with a uterus midline. You can see a mass, again, in the posterior aspect of the cul-de-sac in the midline, and that should immediately alert you to the fact that this could be torsion. So midline ovary, here you can see the remaining grayscale here, but again, this large lead point of the mass. You can see it has a nodule in it, so that makes you think, yep, this could be a teratoma, and those are certainly prone to act as lead points for torsion. There's Doppler flow. Does that dissuade you? Absolutely not. This is torsion, abnormal position, some abnormal grayscale, lead point mass. Trust the grayscale. So I've been mentioning this ovarian pedicle sign as an additional sign of torsion, and this is some examples from the literature. This is, again, a very nice article from JUM, but you can have this sort of target appearance or this echogenic mass, but again, it's circular, and you can almost imagine here, you can see these lamellated layers, basically, of the tube wrapping around each other, and here sort of more of a snail appearance similar to this mass over here. And this is commonly encountered right at the margin of the uterus. So you want to try to look for this, and that will give you supportive evidence that there's torsion. If you can put on the color and you see the vessels actually coiling in this mass, that's even more comforting and more convincing that you are dealing with a patient with torsion. So if you see arterial and venous flow, that's a good sign. That usually indicates that the ovary is viable. If you have flow proximally and no distal flow, that usually indicates ovarian infarction. So can you see this besides ultrasound? Can you see it on CT? And the answer is yes. Here's a patient who had a large cyst and a lot of grayscale abnormality here in the right ovary. You can see it here again in the midline. But on CT, you can also see this mass here with a little bit of enhancement centrally, and this is the twisted pedicle of this ovarian torsion. So the whirlpool sign will add specificity, and it's really useful even when you have flow present in the ovary. In fact, it's encouraging because it tells you that the ovary is salvageable. If you have arterial flow only, some people suggest that that means you need urgent surgical intervention, and if there's no flow at all in that whirlpool, that means you probably are on your way to infarction. So I've mentioned CT here briefly. The CT findings of ovarian torsion are basically the same as you would expect from ultrasound. It's an enlarged midline mass, but in addition with CT we have the advantage of being able to give contrast. So if you have a pre and post contrast image, as I have here, pre-contrast, post-contrast, Hounsfield units actually went down post-contrast. That's partly due to just some background factors, but there's certainly no enhancement of this enlarged midline mass out of normal position. And again, you want to look for that twisted pedicle sign. So here's an example of where it can be helpful. This is a 21-year-old with acute right lower quadrant pain. She has a very large cystic mass lying posterior here to the uterus and a little bit to the right. And her right ovary looked slightly enlarged but not particularly abnormal, and you can see there was a normal Doppler signal obtained from the right ovary. So this was read as a large simple cyst arising from the right ovary, no torsion. However, on CT, you can see that here's a coronal view. You can see that the ovary and the cystic mass are displaced upward and again to the midline. And as you follow this down, you can see that here is your ovary. This is on an axial image. You can see here is the pedicle leading in there, and here's uterus over here. And then when you come down closer to the uterus, away from the ovary, again, you can see this twisted pedicle with enhancement. And this actually was a broad ligament cyst that had twisted the ovary up and acted as the lead point. So it may not be actually a mass in the ovary. It can be a mass adjacent to the ovary that acts as the torque or the lead point for the torsion. So that brings me to my next area, which is what do we do with these large complex masses? Well, they can be difficult because they may mimic a tumor or an abscess, and that can be due to long-standing torsion with hemorrhage or necrosis. And at these points, you need to think more about the clinical features more than the imaging. And let me give you some examples. Here's a patient. She has the classic clinical features of right lower quadrant pain and vomiting, but she has this very bizarre mass. It's actually still over on the right-hand side. It's somewhat septated, and it's mostly fluid-looking on CT. She has an IUD in place, and here is the left-sided ovary. So this was a diagnosis of right ovarian tumor by CT, and they thought it might be a cystadenoma, even an endometrioma, and given the size of the mass, torsion cannot be excluded. This patient went actually directly to surgery, and this was actually ovarian torsion and necrosis. There was no neoplasm found. Here's a perimenopausal woman who had 2 weeks of left lower quadrant pain, fever, and a mass. And you can see here is her bowel, which looks somewhat abnormal. And they thought perhaps from an outside institution she had diverticulitis. You can see the inflammatory changes in the fat. You can see this very large, bizarre mass sitting posterior to her uterus. Bladder here is anterior. On ultrasound, again, very bizarre looking mass. Here is the bladder, transabdominal. Here's the uterus. Here is this mass with some fluid collections. You can see here on transvaginal, these are layering. You almost wonder, are these tubes or are these pelvic abscesses with fluid debris layers that happen to be located one on top of the other? We could find the right ovary, at least on ultrasound. The left one, it says left adnexa area, not sure where the ovary was. So we were left still confused after the ultrasound, and at this point you need to involve your clinicians and they have to make the decision. So they actually thought it was a pelvic abscess, and when they went to the OR, they did call in a gynecologic surgeon as well. and an oncologist because they thought maybe it was a tumor. But when they got to the OR, this was a hemorrhagic torst, left ovary and tube, and it was necrotic and had been there for a while. Now this 22-year-old had several weeks of discomfort. Now she has acute right lower quadrant pain. And again, on CT, this is a funny looking mass, at least with 3 separate collections here. On ultrasound, this one is very echogenic. This is similar with maybe with clot and fluid, and echoes here on the posterior one. On transvaginal, this one has a classic fishnet appearance. So we were thinking perhaps this was some kind of a complex hemorrhagic cyst. We did get good flow in what we thought was some normal ovarian tissue, but because her pain was so severe and because it was such a complex mass, she ended up going to the operating room in part to evacuate it, and this was a large hemorrhagic cyst with no torsion. So is there overlap? Absolutely there is, hopefully not too much. So hemorrhagic cysts can occasionally function as lead points and cause torsion, and they can compress the normal ovary such that you don't see any normal flow. Again, the best discriminator is to find the grayscale version of the ovary, look for an abnormal position, and look for that whirlpool sign. And when in doubt, refer to the clinical signs and consider laparoscopy. So in conclusion, for hemorrhagic cysts, when they're classic, avascular, with that fishnet appearance or the retractile clot, and if they're 5 centimeters or less in a premenopausal patient, these require no follow-up. And you can send the patient confidently on her way without adding additional testing. If there is any question, consider a follow-up ultrasound to see if it resolves over time, or if there is more abnormality, some mural nodules, or something that you think may be a teratoma or an endometrioma, consider getting an MR in that patient. For ovarian torsion, it's the grayscale that you want to count on. Those enlarged ovaries with multiple small follicles are diagnostic. Midline position is highly suggestive. And again, over 50% of torsion cases have a mass as a lead point. So a patient with a mass and pain should raise a red flag, and you should be thinking about torsion. The difficulty arises with masses that compress ovarian flow or in patients with torsion who have persistent flow, so that's our Doppler problem. In those patients, look for that whirlpool sign and or asymmetry with the other side. To avoid missing torsion, you may want to keep a high index of suspicion and accept some negative laparoscopies. So with that, I say thank you, and I hope this is helpful in your practice.
Hello, my name is Dr. Leslie Scout, and I'm Chief of Ultrasound at Yale New Haven Hospital and Professor of Diagnostic Radiology at Yale University School of Medicine. And I'm here today to talk to you about ultrasound evaluation of ovarian torsion, as well as some of the common clinical mimics of ovarian torsion. Today we are going to be talking about the sonographic evaluation of ovarian torsion. And the objectives of this lecture are to describe the clinical presentation of ovarian torsion, to discuss the most common grayscale ultrasound appearances of ovarian torsion, and to describe the role of Doppler ultrasound in the evaluation of patients presenting with clinically suspected ovarian torsion. In addition, at the end of the presentation, I am going to describe the ultrasound findings of common gynecologic clinical mimics of ovarian torsion, in particular hemorrhagic and ruptured ovarian cysts, as well as pelvic inflammatory disease. Ovarian torsion accounts for only approximately 3% of all gynecologic emergencies. It can involve the ovary alone, or the fallopian tube alone, or most commonly involves both. And if it is not surgically relieved, ovarian torsion will ultimately result in ovarian necrosis. Patients are therefore go to surgery when the diagnosis is made, and if the ovary is necrotic, oophorectomy is performed. If clinically, when they're in the operating room, they determine that the ovary is likely to be viable, they can attempt to do detorsion as well as cystectomy if there is an underlying mass present. Unfortunately, however, the ovarian salvage rate is low because it is extremely hard to predict as you're looking at the ovary whether or not it is going to be viable if a detorsion procedure is performed. Patients with ovarian torsion are typically women of reproductive age who present with acute onset of severe pelvic pain, which is more common actually on the right. Patients tend to be afebrile and they have a normal white blood cell count, although occasionally one can see mild leukocytosis. And when patients present with this classical presentation, workup proceeds with immediate Doppler ultrasound evaluation and the diagnosis is quickly made. However, there are very common atypical presentations which you should be aware of. And first of all, although ovarian torsion most commonly occurs in women of reproductive age, it can actually occur in postmenopausal women and children as well as neonates. And in children, ovarian torsion often presents as an abdominal or pelvic mass rather than acute onset of pelvic pain. In addition, another common atypical presentation is that the pain, rather than being sudden, severe, and acute, may actually be relatively mild or intermittent. And in some series, in fact, this intermittent or mild presentation of very minimal pelvic pain has been reported in as many as 50% of cases. And in these patients, these symptoms may mimic GI, renal, or other GYN pathology. And because of this clinical overlap, often a CT scan is the first imaging modality that is obtained rather than an ultrasound. What are the risk factors for ovarian torsion? Well, the most common risk factor is the presence of an ipsilateral adnexal mass. About 20% of cases occur in women who are pregnant, particularly women who have ovarian hyperstimulation syndrome. Pelvic surgery can predispose to torsion, particularly in patients who've undergone tubal ligation. In addition, in children, occasionally lax supporting ovarian ligaments are believed to be the predisposing factor that can result in ovarian torsion. As I mentioned, it is an underlying ovarian mass that is the most common risk factor, and it's estimated that patients have such a mass in about 50 to 80% of all cases. The most common is a dermoid cyst or cystic teratoma of the ovary, but of all adnexal masses, it is the peritubal cyst itself which is most prone to torsion, although a peritubal cyst is is less common than dermoids in the general population. Simple cysts and hemorrhagic cysts can also predispose to torsion, and very, very rarely ovarian cancer can predispose to torsion. Any mass, though, once it causes the adnexa to be greater than 5 centimeters in dimension, predisposes the ovary to torsion. Interestingly, though, this is not true in children, presumably because their pelvis is small, and if a mass is very large, greater than 5 centimeters, it is more likely fixed in place and therefore less likely to rotate along its pedicle. And similarly, in adults, ovarian masses that are extremely large, greater than 12 or 15 centimeters in diameter, again, are less likely to torse because they are fixed within the pelvis and unable to rotate. In terms of children who have normal ovaries and end up with ovarian torsion, this is believed to be due to some type of laxity in the pelvis, either lax supporting ligaments, sometimes due to redundant mesosalpinx, sometimes possibly tubal spasm, and in addition, ovarian torsion in children has been described when there is abrupt change in intra-abdominal pressure because of coughing, vomiting, and sometimes even strenuous exercise. Well, if a patient is suspected of ovarian torsion, Doppler ultrasound should be the first imaging modality that is performed. And it is the grayscale features on ultrasound examination that really are the most important for making this diagnosis. That being said, the appearance of ovarian torsion on grayscale imaging is still quite variable and likely depends on the time since torsion occurred as well as the degree of torsion. The findings that you want to look for, though, on grayscale imaging are first and foremost the presence of an enlarged ovary. As yet, I have never seen an ovary that is normal in size which has undergone torsion, and maybe someday I will, but so far every case of ovarian torsion I've seen, the ovary has been enlarged. The central ovarian stroma tends to be very heterogeneous, with hypoechoic areas due to edema and echogenic areas due to hemorrhagic infarction. And this infiltration of the central stroma tends to displace the follicles in the ovary peripherally, and so one sees a characteristic pattern of peripheral location of small follicular cysts. However, if torsion has been present for a relatively long time, the ovary can be quite amorphous in appearance. Another thing you can look for is an atypical midline position of the ovary. Always check to see if there is an underlying ovarian or adnexal mass. As I mentioned, you will see this in up to 50 to 80% of all cases. If a cyst is present, look for asymmetric thickening of the cyst wall. And also be very careful to try and identify the tube, which is usually between the ovary and the uterus, because often you can see the tube or the pedicle is dilated or edematous. And if you look at it in cross-section, you can see a target sign that looks like a archery target. In addition, it is very common to see a small amount of adjacent free fluid. When the ovary undergoes torsion, the initial thing that happens as the pedicle twists is that the lymphatics are obstructed, and during this early time, blood flow may be normal, but lymphatic obstruction actually is what causes the ovary initially to enlarge and to become edematous. As the obstruction persists, one sees decreased flow through the pedicle. Then one will see reversed diastolic flow. This is followed by decreasing or absence of venous flow, and only after the pedicle has been torqued for a fairly substantial period of time will you see complete absence of arterial flow. So given this progression of pathologic findings over time, it is not surprising that the Doppler characteristics or Doppler findings of ovarian torsion are quite variable. And again, this is mostly due to differences or variability in the length of time from torsion to imaging and also to the degree of torsion. But in addition, there are two arteries that supply blood flow to the ovary, one from the uterus as well as one from the aorta or iliac vessels. And since one of these can torus and not the other, this can sometimes preserve flow to the ovary. Another thing that can affect the Doppler findings is that ovarian torsion in women is very frequently intermittent. And so you can be seeing the torsion during a time of detorsion when blood flow has been restored to the ovary. So what then, though, are the diagnostic ultrasound findings of ovarian torsion? Well, certainly if there is complete absence of arterial flow, this is consistent with the diagnosis of torsion. And another thing that you can look for is the Doppler equivalent of the target sign in the twisted pedicle, which has been termed the whirlpool sign, and I will show you some cases of this in a few minutes. But it is very important to recognize that while those two features, absence of arterial flow and the presence of the color Doppler whirlpool sign, are diagnostic of ovarian torsion, a normal Doppler ultrasound examination does not exclude this diagnosis. As I said, you can have, if you consider absence of arterial flow as being the most important diagnostic criteria for ovarian torsion, you will have a considerable number of false negative exams because flow may be present early on, but you can also have false positive exams, and this can be due to sampling error, the fact that you may not see flow in a normal ovary, particularly in a postmenopausal woman or in a woman where the ovary is deep within the pelvis, and also if through inexperience your machine settings are faulty or not very sensitive. Well, let's go through some examples of ovarian torsion that point out these findings that I've just described. Well, as I said, the sine qua non of ovarian torsion on grayscale imaging is the presence of an enlarged ovary. And so here you see an example of an ovary which is quite enlarged, almost 6 centimeters in diameter. You can see that the central stroma is heterogeneous with hypoechoic areas representing edema and more echogenic areas representing hemorrhagic infarction. You see the peripheral displacement of small follicles, some adjacent free fluid, as well as a simple cyst and a hemorrhagic cyst, which are underlying masses, possibly the lead points causing this ovarian torsion. Here is another example. You see a very, very enlarged ovary. Sometimes there are very few number of peripherally displaced cysts, this very amorphous heterogeneous central stroma, and a very large simple cyst, which was the lead point for this torsion. Here is another example where you can see an abnormal position of the ovary. Notice that it is on the transabdominal image. It is midline in the pelvis, anterior to the uterus here. Note the intrauterine device, which is abnormal in location and within the cervix rather than in the fundus where it belongs. Note again the lead point, this large simple cyst with some reverberation artifact anteriorly. And when you do the endovaginal exam, you can see that the right and left ovary are adjacent to each other. You can see marked asymmetry in the size with the ovary that has undergone torsion, quite a bit larger than the normal ovary. Here again, the lead point, this central amorphous heterogeneous stroma with peripheral displacement of small follicles. And another example, again, an enlarged ovary over 6 centimeters in diameter, peripheral displacement of follicles, adjacent free fluid, and in this particular case you can see a hemorrhagic cyst, which was the lead point for the ovarian torsion. As I said, it's really critical to try and identify the pedicle, and usually you can find the pedicle between the ovary and the uterus, and if it is torused, it will become extremely edematous, as you can see in this case, nicely outlined by some adjacent free fluid. And if you look carefully across section, it has a bullseye or target appearance, just like an archery target, with alternating rings of decreased echogenicity and more echogenic circular structures. And this has been termed the target sign, and again often seen between the torsed ovary and the uterus. Here is the adjacent normal ovary. Here is the very large torsed ovary and the target sign. If you see a cyst and the patient is presenting with acute pain, look at the wall of the cyst, and if you see asymmetric thickening, again, consider the diagnosis of ovarian torsion. And those are the grayscale features which, in my personal experience, you tend to see in the vast majority of patients with ovarian torsion. Well, how about the Doppler examination? Well, let me show you some classic examples in which Doppler is very helpful, and the sine qua non, again, is complete absence of arterial and venous flow. So here you have a classic appearance on grayscale of a torsed ovary, enlarged, peripheral displacement of follicles, adjacent free fluid, heterogeneous stroma, and with color Doppler, no evidence of blood flow. Remember that your spectral Doppler is, of course, more sensitive to blood flow than color Doppler, as is power Doppler, so use both of those modalities to look for flow, and again, they confirm that there's absolutely no evidence of flow within this ovary. And this, again, confirms the diagnosis of ovarian torsion. But I caution you, when the ovary is this classic in appearance for ovarian torsion, I don't really care what the Doppler findings show, because the grayscale findings are enough to make the diagnosis. Here's another example, though, where the Doppler confirmed the grayscale finding. Again, classic appearance of ovarian torsion on grayscale, but on color and spectral Doppler, no evidence of blood flow, just a little bit of noise within the ovarian parenchyma. This is a child who presented with a palpable palpable abdominal mass. You can see the bladder here and the uterus and this extremely large mass with no evidence of blood flow on Doppler examination. And they were concerned about ovarian torsion because they figured any kind of malignancy that was this large would be likely to have flow. And so because they considered the diagnosis of torsion, they did a very interesting thing. They changed transducers and used a high-resolution linear array transducer. They understood that they would not be able to see the entire mass, but they could see to better advantage the more superficial anterior portion, and note that they can, again, with this high-resolution technique, see the peripherally displaced tiny follicles, and this helped confirm their diagnosis that this mass indeed represented ovarian torsion rather than some kind of malignancy. This is the same case that I showed you earlier, where you could see that target sign on the grayscale imaging. And if you put color flow on that area, you'll see the vessels swirling around, and this has been described the whirlpool sign. And if you see this finding, this is a very specific finding for ovarian torsion, but unfortunately it is a very uncommon thing to see. And I've only seen it once or twice in my practice, which is why I've gone to the literature to show you some other examples. And here is from the paper that initially reported this from India, where you can see the target sign, the hypoechoic, echogenic alternating rims on the grayscale, and the swirling vessels on the color Doppler, indicative of both the target and the whirlpool sign. And this is a third example lent to me by a colleague from Johns Hopkins University, again on grayscale, classic appearance of an enlarged tourist ovary, the target sign on the grayscale, and the swirling vessels creating the whirlpool sign on the color Doppler image. But as I mentioned, the Doppler findings can be somewhat variable, again, mostly due to the fact that torsion can be intermittent and variability in the length of time and degree of torsion from onset until imaging with ultrasound. And so here's an example of a patient who's got the classic grayscale features of ovarian torsion. This simple cyst is the lead point. Note the peripherally displaced follicles. But when we put colored and pulse Doppler on, notice that there is some arterial flow, though it is abnormal, as there is a high resistance waveform pattern with absence of diastolic flow. And again, although there is blood flow, it is abnormal, but it is the grayscale findings alone that cause you to make with confidence the diagnosis of ovarian torsion. If you have a question about it, you can consider doing an MRI, as was done in this case. This was early in our experience, and you can see again the ovary is enlarged, the follicles are displaced peripherally. Here is the simple cyst as a lead point, and notice this high signal intensity central ovarian stroma consistent with edema. Again, all the findings that you see on the ultrasound, you see on the MR. Here is another example of a patient who presented with intermittent pelvic pain. Note this left ovary is huge, 8 centimeters in diameter. Again, the classic findings of ovarian torsion. But when we look with color and spectral Doppler, there is both arterial as well as venous flow. However, I want to caution you that the presence of this blood flow should not make you, should not dissuade you from considering the diagnosis of ovarian torsion. All this may mean is that the ovary is in fact viable. So again, when the grayscale findings are classic in appearance, I really don't care what the Doppler looks like. I'm going to make the diagnosis whether I see blood flow or not. And this is the case I showed you at the outset. Again, the classic grayscale findings of ovarian torsion. But on the Doppler exam on color, there's arterial and venous flow confirmed on the spectral examination. Again, this should not dissuade you from making the diagnosis. In fact, this patient should go to the operating room quickly because there is a good chance that the ovary will be viable when they detorse it and therefore will be salvageable. Another example demonstrating blood flow, arterial and venous, in a patient with the classic grayscale features of ovarian torsion. Well, what are some of the pitfalls in the diagnosis of ovarian torsion? Well, it can be difficult when you have a cyst that's possibly hemorrhagic or ruptured to determine if the pain is due to symptoms from the cyst itself or due to torsion, since you know that these cysts also can predispose to ovarian torsion. So this is an example, again, early in our experience, where a patient came into the emergency room with acute onset of pain. This ultrasound was done, a cyst was seen, some adjacent free fluid, arterial and venous flow was identified, and because blood flow was seen, they thought that they should exclude the diagnosis of ovarian torsion, and they thought that the pain was likely to due to leakage from the cyst. But notice that if you look carefully at the rest of the normal ovary, you don't see any normal ovarian architecture. There's some tiny peripherally displaced cysts. There's a very heterogeneous central ovarian stroma. So unfortunately in this case, there are the classic grayscale features of ovarian torsion, but the inexperienced resident was dissuaded from making this diagnosis because of the presence of blood flow. This patient came back to the emergency room 3 days later, noticed that now the ovary is even larger, that cyst is smaller, there is much more echogenic heterogeneity within that ovarian stroma consistent with hemorrhagic infarction, and unfortunately when they went to the operating room at this time, the ovary was infarcted and this woman did lose her ovary. So again, don't let the presence of blood flow dissuade you from making the diagnosis if the grayscale features are classic. This is a patient who had ovarian hyperstimulation syndrome and had just become pregnant, and noticed that her right ovary and her left ovary are extremely large. There are numerous cysts throughout both ovaries, consistent with the diagnosis ovarian hyperstimulation syndrome. And when we did the Doppler, you can see that there was arterial flow to both ovaries. However, on this particular patient, the left ovary was much more tender than the right, even though it looked very similar, and it was tender on examination, so that when the probe was on the left side of the pelvis, the patient was much more uncomfortable than the right. So because of these changes in physical examination, and because we know of the risk of ovarian torsion in women with hyperstimulation syndrome, this patient did go to the operating room, and indeed the left ovary had been torsed, and they were able to salvage it. The only clue, perhaps retrospectively, on evaluating or analyzing the Doppler waveform spectrum is that there's a little less diastolic flow on the left than on the right, possibly indicating increased peripheral vascular resistance due to swelling from the ovarian torsion. Another pitfall in the ultrasound of diagnosis of ovarian torsion is the patient who has chronic torsion. And when the ovary has been infarcted for a while, it becomes extremely amorphous, and sometimes all you see is just a big sac of blood. Notice the low-level echoes within this cystic mass in the left adnexa, or in this case where you see again a big cystic mass just with some clot within it. And so it can have a very, very variable appearance when the torsion has been long-standing. It is most common that either the ovary itself or the ovary and the tube torse, but occasionally, particularly in children, it is possible to torse just the fallopian tube, and this can be very, very difficult to make this diagnosis. But here's a patient who presented with acute pain. The ovary looked normal, and you have no trouble making the diagnosis of hydrosalpinx on the right adnexa. But notice that the hydrosalpinx forms sort of a beak point here, just as if you were to take a balloon and twist it, making a balloon animal at a children's birthday party. This beak sign is not a typical feature of a dilated fallopian tube, which tends to be more dilated actually at the fimbriated end rather than narrowed and pointed as you see here. And so when you see the beak sign in a patient who presents with acute pain, consider the diagnosis of torsion that is isolated to the fallopian tube. And here is another example of a patient showing that big sign in whom just the fallopian tube alone had undergone torsion and the ovary was normal. As I mentioned, it is a dermoid cyst that is the most common lead point in a patient with ovarian torsion, and it can be very difficult to make the diagnosis of a torse dermoid, particularly when it is large. You may not see any of the classic ultrasound features of ovarian torsion because you don't see the normal ovary, so you can't recognize those changes in the ovarian stroma or the displacement of the peripheral follicles. So in my recommendation in terms of dealing with this clinical situation, if you see a patient with a large dermoid, you can't see the ovary to assess the parenchyma, and if that dermoid hurts, you have to assume that it is either torsed or it is leaking. In either case, it is a surgical situation, and you should advise the clinicians that you can't exclude torsion or rupture of the dermoid. You can try using color, but it doesn't really help because often you don't see any blood flow in a dermoid cyst. And as I mentioned, even if you do see blood flow, this does not exclude the diagnosis. So in general, if the dermoid is symptomatic and large and you can't see the ovary, you have to be concerned about the possibility of torsion. Well, what about the patient in whom you have some clinical suspicion and you have some suspicion on the ultrasound findings, but they're not totally classic, they're somewhat equivocal? This is the time when I think MR is very helpful as a problem solver. So this is a patient who had very mild pain, had been intermittent over several months. When we did the endovaginal exam, we can see that there is some asymmetry in the size of the ovaries. The right ovary was just over 5 centimeters, the left 3.5. The right ovary, therefore, clearly bigger. Again, some peripheral displacement of follicles, but you can see that on the normal left ovary as well, and the central stroma a little bit more prominent. This patient did have arterial flow and venous flow, which I haven't shown you, but there was asymmetry in the size of the ovaries. But because it wasn't that dramatic and the patient's symptoms weren't that dramatic, we weren't really sure if this was a torsion or not. And in this case, we ended up recommending that they do an MR. And MR is very useful as a problem solver. That being said, it actually shows you very similar things to what I've described on the ultrasound examination. The ovary that is torsed on MR is going to be enlarged. It's going to be abnormal in location. Note this midline position. There is going to be a high signal intensity central stroma due to edema, and you will see peripheral displacement of follicles. One thing that you can do with MR that you can't do with ultrasound easily in the United States, since intravenous ultrasound contrast is not yet FDA approved, is you can give intravenous contrast, and with intravenous contrast you'll see that there is lack of contrast enhancement, and sometimes that can help you identify also the thickened fallopian tube, which in this case was a little bit hard to differentiate from the ovary until we gave the contrast. Here is another example. This is a pediatric patient in which the ultrasound wasn't diagnostic and they didn't have a good explanation for the patient's pain. And on the MR, you can see the findings of ovarian torsion. Here is the hemorrhagic cyst and a serous cyst, either one of which could have been the lead point. You can see increased signal consistent with edema in the residual ovarian parenchyma, peripheral displacement of little follicles, and you see this round swirling mass between the ovary and the uterus representing the twisted, thickened pedicle. And following contrast enhancement, no enhancement in the ovary and just a little bit of enhancement in that pedicle in this patient with ovarian torsion. I want to spend just a few minutes talking about the appearance of ovarian torsion on CT scan, even though this is an ultrasound lecture. And the reason for that is that in these patients with atypical presentation who present with mild or intermittent symptoms that mimic GI or renal or even other gynecologic pathology, sometimes a CT scan may be the first imaging test that's obtained, and so it's important that one be able to recognize the appearance of ovarian torsion on CT. And just like on MR, the appearances of ovarian torsion on CT mimic exactly what I've described on ultrasound. So you see an enlarged midline ovary, peripheral cysts, and a thickened adjacent pedicle, as well as a heterogeneous central ovarian stroma, sometimes increased in attenuation due to hematoma, areas of decreased attenuation due to edema. Another example lent to me by Dr. Lefthoff, now at the University of Pennsylvania, where you can see again these peripheral follicles, this thickened adjacent fallopian tube, and stranding in the pelvic fat, which is a nonspecific finding on CT of inflammation or infection. Another example from Dr. Lefthoff showing the lead point, this simple cyst here with a star, the underlying mass, as well as this thickened fallopian tube between the ovary and the uterine cornua. And on CT, just like with MR, you can give intravenous contrast. Notice there is no enhancement of this torsed and infarcted ovary. Notice, just like on ultrasound, you can see some adjacent free fluid, sometimes of high attenuation, indicating pelvic hematoma. Well, those are is a brief summary of the ultrasound, CT, and MR appearances of ovarian torsion. But as you evaluate these symptomatic patients, it's also important to differentiate ovarian torsion from other common causes of acute pelvic pain in the woman of reproductive age. And the three things that I want to talk about at the end of this lecture are hemorrhagic cysts, ruptured ovarian cysts, as well as pelvic inflammatory disease. And if you take women of reproductive age, all women who come to the emergency room or who present with acute pelvic pain, actually hemorrhagic cysts are the most common cause of acute pelvic pain in these women. And so it's very important to recognize the ultrasound findings to make this diagnosis with confidence. Patients with hemorrhagic cysts, these hemorrhagic cysts may have a variable pattern of internal echogenicity, but one of the key features is this pattern will change and evolve over time. These are cysts, so the wall should be thin and regular, although it may be vascular. Because they are cysts, they will demonstrate increased through transmission, and no matter what the pattern of internal echogenicity, there should be no evidence of internal vascularity. When a patient presents to the emergency room acutely within the first several hours of hemorrhage into an ovarian cyst, the typical pattern that you see is, as I've presented here, one of diffuse, homogeneous, low-level echoes. So here is a cyst, thin wall, some increased through transmission, and diffuse, low-level echoes in a homogeneous pattern throughout the hemorrhagic cyst. As time moves on, what happens is that the red blood cells lyse and they release their contents into the cystic fluid, and fibrin strands form. And these can form a lace-like or spider web, sometimes people call it as a fishnet pattern of internal echoes and septations. And they can be sort of minimal, as you see on the example on your left, or they can be more echogenic and more confluent, as on the example on your right. And over time, they tend to coalesce to form the clot, so they tend to point towards a particular focus, often associated with the wall, because the clot is often adherent to the wall. And the next thing that happens is that these septations, as I said, evolve into acute clot, and this clot acutely tends to be echogenic. Most often it's adherent to the wall. It can be kind of polypoid in configuration, as you see here, but sometimes that echogenic clot can actually be suspended within the cyst, and this really does look like a spider web with maybe some kind of a fly or bug caught in the fibrin strands within this hemorrhagic cyst. Over time, that clot is going to change, and the fluid within it is going to be absorbed, and it's going to become retractile. And this can be diagnosed on ultrasound by the identification of the sharp or concave margins, and this is very typical for retractile clot and is very uncommon to see with any kind of soft tissue mass. Here are two other examples showing these concaved, scalloped margins, very straight margins. This would be very atypical for any kind of soft tissue component or neoplasm, and here again a very, very straight margin. Very unlikely that any neoplasm would have that kind of a configuration. Well, what do you do, though, if you see a patient who's got a little echogenic focus within a cyst in the ovary, and you have to differentiate between clot and a mural nodule? Because if you see a mural nodule or a soft tissue component, you, of course, are going to be concerned that there's an underlying cystic epithelial neoplasm. Well, one of the first things you can do actually is to roll the patient, and if that clot moves or layers, just like sludge within the gallbladder, and here you can see a very flat interface between that hemorrhage and the rest of the fluid within the cyst, you know this is not going to be a mural nodule, and this is just going to be hemorrhage. And the other thing, of course, that you're going to do is to check your vascularity with your color, power, as well as spectral Doppler. And if you see any blood flow, you have an answer. You know this has to be a neoplasm or some sort of a tumor nodule. If you don't see blood flow, it's most likely to be clot, but you need to remember that sometimes when mural nodules from tumors are small, they may have so little blood flow that it's below the resolution of your ultrasound machine. And so for that reason, we tend to get follow-up, because again, clot or internal echoes, no matter the appearance, should have no evidence of vascularity. But because you can't necessarily differentiate a small tumor nodule from clot if you don't see blood flow, we do recommend getting follow-up. And the typical time frame that we get this follow-up is within about 6 weeks. And again, This is very important, particularly if the clinical presentation is somewhat atypical. In other words, the patient didn't have pain and you see a hemorrhagic cyst but there are no symptoms, or if it doesn't really look typical for the clot that I've shown you, you don't see those straight concave margins. In 6 weeks, clot should change in appearance, and if the echogenic focus does not change in 6 weeks or doesn't resolve, or if you see blood flow, in either case you have to consider that there is a tumor nodule there, and it then becomes a surgical lesion. Well, what about rupture of a cyst? This again is a very common cause of pain, and often the pain is not only acute but extremely severe. These patients may have rebound tenderness. If they lose a lot of blood, they may even be hypotensive. Typically, they have a normal white blood cell count and they are afebrile. Well, how do you make the diagnosis of ovarian cyst rupture in ultrasound examination? Well, first of all, it sometimes is a diagnosis of exclusion. In other words, the ultrasound examination is completely normal. Why is that? Well, the cyst rupture, the fluid dissipates within the pelvis and is absorbed, so with the cyst being ruptured, you don't see it anymore, and you don't even see the adjacent fluid. But sometimes the cyst doesn't rupture completely, and it will look crenated with a pointy, abnormal configuration with straight margins. It may contain some internal debris, and you may see some fluid adjacent to the ovary or within the cul-de-sac, sometimes even in Morrison's pouch if there's been a lot of bleeding, and sometimes you can actually see a clot within the fluid. Look carefully for these low-level echoes indicating that this is hemorrhagic fluid. Here is an example of a patient who has a ruptured cyst. You can see the ovary here, and the cyst is a very crenated configuration with angular margins. And note that this ovary is surrounded by a lot of amorphous material, and this is clot that actually seems to almost be engulfing this ovary. When you see this much clot, very important to look in the cul-de-sac. Notice that there is a lot of clot in the cul-de-sac posterior to the uterus and in the anterior cul-de-sac anteriorly as well. And when you see this much clot, look throughout the rest of the abdomen and in the upper quadrants in order to quantify the amount of hemoperitoneum. And here in this patient in the pelvis and in the flanks, you can see a huge amount of fluid surrounding these loops of bowel with a lot of low-level echoes within them, indicative that this is hemorrhagic fluid. Here's another example where you can see the ovary surrounded by a huge amount of clot. There's blood flow to the ovary, so you know there's no, so you can identify that this is ovary, but the clot has no blood flow, of course, within it. And in this particular case, you can't see the cyst anymore because it's ruptured. All you see is the hemoperitoneum around it. But again, always look elsewhere in the pelvis. And this patient had a huge clot in the cul-de-sac behind the uterus. Here you can see it on sagittal. A lot of free fluid in the anterior cul-de-sac, and note that there's even fluid in the upper quadrants here surrounding the spleen. And this patient was very unstable and actually ended up getting a CT scan. I'm actually not sure why they didn't just go to the operating room, but the CT scan shows just what we saw in the ultrasound. So fluid around the liver and around the spleen, and a huge amount of fluid within the pelvis, some of it showing high attenuation consistent with active bleeding. And this patient had to go to the operating room because she was unstable just from bleeding from her hemorrhagic cyst. And the last thing I want to mention as a relatively common cause of acute pelvic pain in women of reproductive age is pelvic inflammatory disease. This is an ascending infection. It begins at the cervix, and these bacteria move up through the endometrial cavity, out through the fallopian tube and into the pelvis to surround the ovaries. And currently in the United States, chlamydia is the most common cause of pelvic inflammatory disease. In past years, gonorrhea, of course, was the most typical cause of PID in women in the United States, but this has been supplanted now by chlamydia infection. The clinical presentation of patients with PID can be quite variable, and the symptoms can be very minor or vague, and then can be as extreme as an acute onset of severe pain. Unlike the patients with ovarian torsion or hemorrhagic cysts, these patients tend to be febrile. They have an elevated white blood cell count. They may have a purulent vaginal discharge and will have cervical motion tenderness on exam. Well, in ultrasound, you don't ever see the cervicitis, so this is not a diagnosis you can make with ultrasound, but you can start to see findings once those bacteria extend into the endometrial cavity. And the first thing that you might see is endometritis. So what are the findings of endometritis on ultrasound? Well, the first thing is that the endometrial stripe becomes indistinct and sometimes thickened. So here's a sagittal view of the uterus of a woman with pelvic inflammatory disease. I can see a little bit of fluid within the endometrial canal, but I cannot see the endometrial stripe. I would have no idea how to measure it, and so for me this is a very, very indistinct endometrial stripe. Now, depending upon the organism that has caused the infection, if it's a gas-forming organism, you can actually see echogenic foci within the distended endometrial cavity with shadowing because of the gas, and sometimes you can see fluid and a lot of debris distending the endometrial canal. Endometritis is often associated with marked increase in vascularity, and this will have an abnormal arterial waveform pattern characterized by a lot of diastolic flow, different from the normal high resistance waveform pattern in the normal uterine artery. Now, those bugs continue on their path up through the endometrial canal and out into the fallopian tubes, and so the next thing that develops is salpingitis, or inflammation of the fallopian tubes. And what you see on ultrasound is a very thick, inflamed fallopian tube. It's not normal on most patients to actually even be able to identify the fallopian tube unless there's ascites in the pelvis. So when you see the fallopian tube and it looks thick like this, you have to be concerned about inflammation, and often it will be very vascular if the infection is acute. The fallopian tube will become obstructed, and then it becomes filled with pus and debris, so you can see a lot of fluid in this markedly distended tubular serpiginous fallopian tube. Again, the debris, the low-level echoes representing pus, and also the wall, again, often very vascular if this is acute. Sometimes that pus and debris will layer, as you see in this very distended serpiginous fallopian tube. And it's in patients with chronic PID, sometimes you don't see as much pus in the tube, and so it's important that you know how to identify a fallopian tube and differentiate that from other cystic structures in the adnexa. And three things to think about. One is the waist sign, and this is a little pinching off, if you will, indentation of part of that tube, and that occurs because that fimbriated end is typically more dilated than the rest of the fallopian tube. Another thing that you can look for is the cogwheel sign, and this is the presence of these little nodules seen often best in cross-section. These are just the thickened mucosal ridges or striations, which are commonly seen in the fallopian tube. But I should caution you that you can see mural nodules like this with malignancy, so this shouldn't be the only sign that you use to make the diagnosis of a hydro or a pyosalpinx. And the last thing that you should look for, which is considered really the most specific thing, again, if you go back to that analogy that I mentioned earlier of the balloon animal, if you think of the fallopian tube as a big long balloon and you fold it on itself, you see these incomplete septation sign, which is just the two walls of part of the tube as it folds on itself. So anytime you see a septation that doesn't extend from one side of a cystic area to the other, think of a fallopian tube that is just folded upon itself. As the pus exits from the fimbriated end of the fallopian tube, it spills into the peritoneal cavity, and it may coat the surface of the uterus, causing this hypoechoic rim around the uterus, and this is what you see in patients who have uterine serositis. And this can form adhesions, and so sometimes you can see that the rectum, or in this case the ovary, is attached to the uterus, and instead of the normal acute angles that you see between the ovary and the uterine fundus, you can see these straight margins due to this hypoechoic pussy substance, again causing adhesions between the serosal surface of the uterus and the ovary. And the last thing that will happen is that all of this infection and inflammation will engulf the ovaries, and the patient will develop tubo-ovarian abscesses. And these are typically complex, multilocular, thick-walled masses containing variable patterns of internal echoes. Again, often bilateral ovaries, often seen together in the cul-de-sac or anterior to the uterus. Another example showing very complex vascular bilateral adnexal masses. Here you can see the distended fallopian tube and these low-level echoes within the cystic components. These masses tend to be tender and tend to demonstrate a lot of increased vascularity, and as I said, tend to be bilateral. And again, it's very important to talk to the patient, and they'll let you know if their mass is painful, and if the mass is painful, again, think strongly of a tubal ovarian abscess. Now, when you see a complex mass in the pelvis, and it is tender, but you can actually see the ovary separately surrounded by inflammation. This is best termed not a tubal ovarian abscess, but as best described as a tubal ovarian complex. And it's important to recognize this because if the ovary is preserved, and it often is preserved a while from involvement of infection by the ovarian capsule, which is a barrier to the spread of infection, this will respond better to antibiotics, and so often these patients deserve a trial of antibiotics before they have any kind of a drainage procedure or surgery. And another thing that has been described recently is that the pelvic fat in patients who have inflammation or infection tends to become echogenic. This is not a specific finding for pelvic inflammatory disease and can be seen in patients with diverticulitis or inflammatory bowel disease. But in patients with PID, you'll see this increased echogenicity of the pelvic fat around the adnexa and around the uterus, as you see here. And if you see this, this increases your sensitivity for making this diagnosis. So in conclusion, in a patient with ovarian torsion, or with clinical suspicion, I should say, of ovarian torsion, don't be dissuaded by the history. Not all patients with ovarian torsion present with acute severe pain. In many patients, the pain is relatively mild or intermittent. Focus on the grayscale imaging features to make this diagnosis. Look for an enlarged ovary with a heterogeneous central stroma with areas of increased and decreased echogenicity, peripheral displacement of small follicular cysts, an abnormal midline location, and look between the enlarged ovary and the uterus to find that thickened adjacent pedicle, which on cross-section might show that target sign. When you do the Doppler examination, and we do this in all patients, do look for absence of flow, abnormal flow, and the whirlpool sign, because the absence of flow and that whirlpool sign are diagnostic findings for ovarian torsion. But don't be dissuaded by the presence of blood flow. Don't let this keep you from making the diagnosis of ovarian torsion if the grayscale features are classic. In fact, the presence of blood flow in a patient with ovarian torsion may be a good thing and may indicate that the ovary is salvageable. Look for similar findings on CT and use MRI as a problem solver. So again, on CT, you'll see an enlarged midline, non-enhancing ovary with a thickened adjacent tube. And again, MR, you'll see the same thing, though often it's a little bit easier to see the pedicle and the increased signal intensity of that central ovarian stroma. In terms of hemorrhagic cysts, remember the key feature here is that there will be no Doppler flow except in the cyst wall, no matter what the pattern of internal echogenicity. Remember to get follow-up because clot will resolve or get smaller after 6 weeks. And remember that in patients who've ruptured or hemorrhaged, occasionally they can develop massive hemoperitoneum that requires surgery in order to stabilize them. In terms of patients with pelvic inflammatory disease, the most common finding, of course, is the presence of a complex, tender, vascular, and bilateral adnexal masses. But look carefully for some of these more subtle findings that I've described of PID, such as uterine serositis, echogenic pelvic fat, and that dilated adjacent tube, because this will increase your sensitivity for making this diagnosis. Thank you for your attention.